Someone recording us. You better not say anything.
Oh, it's just this. Awesome.
Which one? Is it going in and out? This is going to be kind of the agenda screen that I could just leave up during transitions. I think it's open.
Oh, is it? Okay.
So it will be open as a transition.
it gonna be mainly pulmonary medicine attending, or do you feel like?
Most of it's pulmonary, actually, so pulmonary and critical care also, but I think in this particular case, which it's the audience target is technically pulmonary, yeah, fellows and stuff, yeah. Hello and welcome, everyone. Can everybody hear me? Chat box is also, there's nothing in the chat box right now, so. All right, welcome everyone to our Sarcoidosis Symposium. We have some excellent talks and some great speakers. We'd like to approach first with some of our consultants and go from a system-based approach, where our first talk is cardiac sarcoidosis by Dr. Lindsay Aurora. And we also have Dr. Anand as our expert opinion available also. So we will get started.
All right, I'm just going to share the screen here. And can you hear me always?
Yes.
Oh, you can. Okay, wonderful. All right. Good afternoon, everyone. My name is Lindsay Aurora. I'm one of the cardiology fellows in cardiology. And thank you for having Dr. Anand and I speak to you about cardiac sarcoid diagnosis and management. And we'll kind of cover the main topics over the next half hour. So let's get started. 1 second. All right, so just a little bit of background. Now, sarcoidosis is a diagnosis of exclusion. There's no reliable biomarker for establishing diagnosis or disease monitoring. Now, this is usually characterized by non-necrotizing granulomas, which is an essential feature of the disease. But keep in mind that these pathologic findings are not specific to sarcoid. They can actually be seen in numerous infectious inflammatory diseases. Cardiac and pulmonary involvement in sarcoid is associated with a greater mortality than other manifestations. And of course, diagnosis should consider the clinical presentation, histological evidence of granulomatous inflammation, and of course, exclusion of other diseases that perhaps could cause the same presentation. Now, cardiac involvement in sarcoid has been reported in about 25 to 60% of autopsy studies, with the highest prevalence described in actually Japanese cohorts. Now, lungs and intrathoracic lymph nodes are involved in 90 to 95% of cases, but the exact prevalence of cardiac sarcoid remains largely unknown. In fact, clinically overt cardiac sarcoid has been reported in 5 to 10% of cases with systemic sarcoid. Sorry, just 1 second. I hear that you can't hear me. Okay, let me just.
No, we can hear you.
Oh, okay. I just got a message from Away, so let me just make sure. Okay.
I'm able to hear you at least.
Okay.
This is Anand.
Okay, yeah, and now, yeah, Doctor. I'm just calling him.
Yeah, I think it may be his phone or something.
Can you hear me? Or
other people can hear you. Yeah.
Okay, perfect. Okay, I'll just start on this slide if that's okay. Perfect. Okay. All right. I think we have solved our technical issues. Okay, so let me just kind of start back up for those who can hear me. So cardiac involvement in sarcoid has been reported in 25 to 60% of autopsy studies. Highest prevalence described in Japanese cohorts. Again, lungs and intrathoracic lymph nodes are usually involved in about 90 to 95%, but the exact prevalence, and that's the point here, of cardiac sarcoid remains largely unknown. So clinically overt cardiac sarcoid has been reported in 5 to 10% of cases with systemic sarcoid. Now, granulomas in cardiac sarcoid can be found anywhere in the heart, more commonly in the left ventricle interventricular septum. And disease manifestations depend on the location, extent, and the stage of the inflammatory process. So with greater involvement usually resulting in more symptoms. Symptoms commonly including conduction abnormalities, arrhythmias, and less commonly heart failure. And that's why patients can present with a history of palpitations, pre-syncope, syncope, right bundle, AV block ranging from 1st to 3rd degree, which is usually the most common manifestations. And again, both AV blocks and history of VT or ventricular tachycardia increase the risk of sudden cardiac death. In fact, sudden cardiac death can be the first and only manifestation of the disease in some cases. It accounts in some studies for as much as more than 50% of deaths per literature. Now, RV involvement is also quite common and ranges from about 6 to 65%. Again, this depends on the studies, and it's reflective of either granulomatous disease of the right ventricle or hemodynamic sequelae of longstanding cardiomyopathy or pulmonary hypertension. And the presence of RV involvement is considered a marker of poor outcome. So RV late gadolinium enhancement actually is a marker, or it portends an increased risk of ventricular tachyarrhythmias. RV dysfunction secondary to PH can be seen in actually patients with extensive lung fibrosis. There have been surveys in sarcoid clinics that have identified pulmonary hypertension in about 5 to 20% of cases, with up to half of these persistently patients who are dyspneic having sarcoid-associated pulmonary hypertension. Now, isolated cardiac sarcoid in the absence of extracardiac evidence of disease, again, has a prevalence of 30 to 50%, and presence of cardiac involvement, as just clinically manifested cardiac involvement, has been associated with a poor outcome, as you can imagine. Japanese studies have identified cardiac sarcoid as the leading cardiac cause of mortality in their sarcoid population, with up to 85% dying from cardiac complications. Now, there are more recent reports that perhaps suggest a better prognosis. There was a group out of Finland that looked at 110 Finnish patients with biopsy-proven cardiac sarcoid. And they found that with the current available therapies, they did actually much better than anticipated. So they're just for some statistics, so to the 10-year likelihood of transplantation-free survival was 83% overall, and 91% in patients who were actually receiving immunosuppression therapy. Now, despite encouraging outcome data, determining prognosis remains challenging, and that it's mostly based on traditional outcome metrics. So we can look at left ventricular dysfunction, we can look at history of malignant arrhythmias or extent of late gadolinium enhancement, with this latter actually showing superiority to some of the standard prognostic parameters, such as perhaps EF or cardiac volumes, in predicting worse outcomes. The availability of biomarker or a cluster of biomarkers with diagnostic power remains a missing piece. And similar to pulmonary sarcoid, biomarkers such as ACE inhibitor or BNP, high sensitivity troponins, they're often elevated in patients with cardiac sarcoid, but these tests have low sensitivity and specificity. There are other markers that are being studied, such as serum amyloid A proteins like TGF-beta, on their potential roles, but again, none can be readily used to diagnose or assess the activity of this disease. Now let's kind of go over a diagnostic approach. So endomyocardial biopsy is the gold standard to establish diagnosis, but it's important to keep in mind that it has low sensitivity of less than 25% because of the patchy or focal distribution of granulomas that can often result in sampling error. Now, cardiac MR can be used as a guide for biopsy to increase the diagnostic accuracy. Even more so, you can use voltage-guided biopsy procedures. And the idea here is that you're using electroanatomic mapping to guide your biopsy. And usually when you see areas with like fragmented signals without any isoelectric segments, it's thought that perhaps those show active disease. Now, without confirmatory tissue diagnosis, clinical guidelines combine proof of extracardiac disease with evidence of cardiac involvement that's commonly used in the guidelines. The JMHW, which stands for Japanese Ministry of Health and Welfare, they initially published the criteria in 1993, modified later on, most recently in 2017. And again, this combines the confirmation of extracardiac sarcoid or a combination of major and minor criteria that we'll briefly look at. The revised 2017 document from the JCS, or the Japanese Circulation Society, includes PET and MR among the major diagnostic criteria for cardiac sarcoid. And again, compared with the Japanese Ministry of Health Welfare, the HRS criteria actually have greater sensitivity because you're including cardiac PET, MR, you're also including responsiveness to therapy, steroid therapy specifically. So this is kind of the two criteria that we look at. The JCS and the HRS, currently the two most well-established diagnostic guidelines. Now, keep in mind that these are based on expert consensus and they have yet to be validated by prospective data or I guess clinical trials. And the HRS criteria on the left side is the most commonly used. So again, briefly looking at it on the left side, we're looking at histological diagnosis. Then you're looking at clinical data from invasive or non-invasive studies, such as perhaps if they're responding to steroid, immunosuppression, you're looking at their EF, any arrhythmias. Similarly, on the right-hand side with the JCS, you're looking at major and minor criteria along with histological diagnosis. One thing to note, the pattern of scar detecting on MR, which is one of the the guidelines as well, or criteria, with late gadolinium enhancement is classically described as non-ischemic, and it preferentially involves the subepicardium and the mid-myocardium. And I'll kind of expand on that in a little bit. Now, initial imaging modalities, as you can imagine, we start with a chest X-ray, CT. They're most commonly available. Again, chest X-ray, you can look at lung, lymph node involvement, mediastinal or hilar lymphadenopathy, which actually, and this chest X-ray can be abnormal in more than 90% of patients with extracardiac sarcoid. High resolution CT can, of course, enable better analysis of the parenchyma and interstitial involvement. But again, this will not make you exclude cardiac sarcoid just based on negative chest imaging. Edema, granulomatous inflammation, and fibrosis with cardiac sarcoid can result in ECG abnormalities. And again, this is present in about 3 to 9%, as you're seeing, of patients with clinically silent cardiac sarcoid. You can have PVCs, or premature ventricular complexes, as I mentioned, different varying degrees of AV block, abnormal axis, Q waves, which are commonly associated. And evidence of these EKG changes is generally a trigger for further investigations, right? You can do a 24-hour Holter monitor to perhaps detect subclinical arrhythmias that could be missed on an ECG. But keep in mind that the abnormalities noted on the ECG or Holter are sometimes nonspecific and insensitive, right, to examine your cardiac involvement in patients with sarcoid. Now, transthoracic echo can often be used, right? We're identifying patients with known extracardiac sarcoid that perhaps might have cardiac involvement, or for monitoring disease progression. As I mentioned before, the common findings that you're looking at is non-coronary distribution of wall motion abnormalities. You can see thinning of the anterior basal septum, sometimes with increased echogenicity, aneurysm of the interventricular septum. Other abnormalities you can see left or right ventricular systolic dysfunction. You can have valvular abnormalities and even pericardial effusions for that matter. Now, global longitudinal strain, that's essentially when you're looking at longitudinal shortening as a percentage, so basically change in length. And again, the sensitivity and specificity in cardiac sarcoid, and again, this is per studies in the literature, ranges from 60 to 90%, and the normal range has yet to be validated. But again, another parameter that you can perhaps look at. Now, in isolation, as you can imagine, echo also lacks sensitivity and specificity, right? Because a normal or an abnormal echo is not going to rule in or out the disease in the absence of a confirmatory biopsy. Now, how about cardiac sarcoid with extracardiac disease? So when you have biopsy-proven extracardiac sarcoid, a positive MRI or cardiac MRI is generally indicative of probable cardiac sarcoid, but a negative one cannot exclude earlier subclinical disease. The good and the advantage of cardiac MR is that it offers high spatial resolution. You can have a detailed assessment of your LV and RV, or your left and right ventricle. You can see detection of edema, perfusion defects, perhaps a myocardial scar. And oftentimes an acute phase of the disease, so the main hallmark features that we look at, as I mentioned, non-coronary wall motion abnormalities, you can see increased myocardial wall thickness or increased signal intensity. And then chronic phase or inactive, oftentimes you can see myocardial wall thinning or aneurysm also. And then you can use multiparametric MR imaging with T2 mapping to evaluate for edema. But here where you can see edema or inflammation before there's any detectable changes in your ejection fraction or late gadolinium enhancement. But again, the diagnostic accuracy of T2 is a little bit uncertain, is undergoing investigation. But MR can give you the ability to distinguish between scar fibrosis versus active disease, perhaps before you start treatment. Now this is, if you can see the screen properly. So this essentially is looking at different patterns of delayed gadolinium enhancement on a cardiac MRI. So as I mentioned, one of the most important diagnostic findings through this, you can see late gadolinium enhancement. So essentially detection of macroscopic interstitial fibrosis, which can happen in both acute and chronic. And these are the different patterns. So for example, in pattern A, you're looking at late gadolinium enhancement in the anterolateral wall, all the way down to patient D, where you kind of see it in the inferolateral, the inferior, the white outline that you can see. So just different patterns that are definitely things to keep in mind. Now, PET and CT. So let's go over this. So PET is a radionuclide imaging technique. So it's usually used in combination with a CAT scan to detect active metabolic processes in the body. So the typical protocols for cardiac sarcoid include using F18 or FDG PET for imaging inflammation. That's kind of the main point. And you're combining this with SPECT or PET for myocardial perfusion imaging. Now, the images produced by PET-CT have a higher spatial resolution compared with other nuclear imaging modalities. And this also has a technical advantage of you have lower radiation exposure, you have a built-in attenuation correction, you can localize anatomically. And here, the combined sensitivity and specificity is estimated up to 89 and 78%. And this can be used to monitor disease activity or follow-up. Now, FDG, so the cellular uptake of FDG is related to inflammatory cell infiltrates. And just the mechanism of action that I want to touch base on briefly, so if you think about it, your active inflammatory cells, they have high glycolytic activity. So you're satisfying, their large energy demands. And so consequently, they're producing a lot of ATP. So basically almost greater than 6-fold higher than baseline. Now, after it crosses the cellular membrane using glucose transporters, both FDG and glucose are phosphorylated. And when glucose is further metabolized, the phosphorylated FDG is actually trapped within the cell and you can image it. So as FDG accumulates in active lesions where the cells that are inflamed utilize glucose as an energy source, then you can actually image active sarcoid lesions because of increased FDG uptake. So that's kind of the whole mechanism of how we are using the concept of cellular uptake of FDG to image. Now, this again is an essential modality PET, for early diagnosis and management. One study actually directly compared the diagnostic accuracy of PET with cardiac MR. Now, PET has a higher sensitivity, but a lower specificity than cardiac MR. And the differences come because the capability of PET in identifying an active lesion, so an early stage, versus late gadolinium enhancement in identifying fibrosis, advanced stage, through an MR. And that's the most likely explanation of the differences in the sensitivity and specificity of these two imaging modalities. Now, serial PET scans can be used to determine treatment option and monitor treatment response, as I mentioned. And again, this is due to the ability because you can quantify the metabolically active lesions. So what are some of the limitations though? So there are a high rate of false positive scans because of the inadequate suppression of the physiological myocardial uptake. And that's actually affected by dietary preparation. So on that note, there is a special patient preparation that's required before PET imaging to adequately suppress the myocardial FDG uptake and increase the utilization of free fatty acids by the cardiac muscle. And so the whole idea here is that we want to shift our myocardial metabolism to fatty acid and suppress the glucose utilization and FDG uptake by the normal myocardium. So you can detect the inflammation within the sarcoid granulomas. So just a little bit of background, normal myocytes utilize glucose as one of their main energy sources. So in order to suppress, there's actually different mechanisms that we can do so. And the current approaches are actually you can avoid strenuous exercise for 24 hours. You give the patients a low carb meal and high fat diet, prolonged fasting for greater than 12 hours. And you actually can give them, or we give them IV unfractionated heparin. And the way this works, it actually activates lipoprotein and hepatic lipases. So you increase your plasma free fatty acid levels. And then essentially that causes a reduction in the glucose consumption of normal myocytes. Now, this table here, I think it's quite nice here as it demonstrates perfusion and metabolism patterns in various stages of cardiac sarcoid. As you recall, when I mentioned that typical radionuclide protocols for imaging sarcoid here, we use our FDG PET for inflammation and combined with SPECT or PET for perfusion imaging. So if we kind of just walk through this, when we look at the normal at the first row, there's no perfusion defect and there's actually no uptake. On the FDG uptake column, that's all the radionucleotide in the blood pool. So there's no focal uptake in the myocardium. And as you go down in the early and progressive, you're seeing perfusion defects and then concomitant FDG uptake. Now keep in mind here that a reduction in FDG uptake could mean resolution of inflammation, so normal at the top, or progression of the disease process and fibrosis, so the fibrosis at the last row. And that's why perfusion imaging is super critical, even on the follow-up scans, so that we can differentiate between these two aspects. Because perfusion should be normalized in normal, and then it would be worse in the fibrosis, as you can tell in the perfusion defect where you see that gap. Now, there are limitations with this that, screening for cardiac involvement, of course, should be pursued with history of cardiac sarcoid or history of sarcoid and cardiac symptoms. But again, the approach to patients with the diagnosis of extracardiac disease, but those who are asymptomatic, it's still up for discussion. because it's uncertain if subclinical disease should be treated, whether then there's more than one subgroup that perhaps exists in this population. And again, what's their prognosis? So HRS gave a class 3 recommendation to screening for cardiac involvement in patients without symptoms or an EKG or transthoracic echo. And qualitative interpretation of the PET scans is also another limitation. If they're reported as positive or negative, do not perhaps accurately grade disease severity. And then the uncertainty in the setting of negative scan, what's the period during which patients remain at low risk after that scan? And I guess essentially what is the warranty period? And that's up for discussion as well. And then on that note, just to pose a question to everyone listening, how would you manage an asymptomatic sarcoid patient with abnormal ECG findings? And discussing within the sarcoid group and the practice for asymptomatic patients, if you have abnormal ECG findings, perhaps you should start with a transthoracic echo and a Holter monitor. Now, if those are negative, then maybe no further workup is indicated, but you can maybe do an annual ECG, check on symptoms. If there are abnormalities on that note, though, the next step, if there's abnormalities on the Holter or the echo, you could do a cardiac MRI, and then you can refer them to cardiology within the sarcoid group for routine follow-up. Now, cardiac sarcoid without extracardiac disease. So in the absence of extracardiac manifestations, the identification is tricky, right? We've kind of gone through the main things here. Changes on ECG or transthoracic echo lack sensitivity and specificity, unlikely to offer any additional diagnostic benefit if you don't have a tissue biopsy or tissue diagnosis. Now, abnormal late gadolinium enhancement patterns on MR imaging is usually a trigger to consider cardiac sarcoidosis, perhaps more so than an unspecified cardiomyopathy. But at the same time, we have to keep in mind the other differential diagnosis, right? We can consider arrhythmogenic right ventricular cardiomyopathy. But in this case, compared with cardiac sarcoid, the RV is classically more involved. There's sparing of the septum, no history of conduction abnormalities. You can also think about myocarditis, right? It can mimic cardiac sarcoid. You can present with late gadolinium enhancement in the subepicardia mid-wall as well. But usually patients with myocarditis usually have a more acute presentation. It can also be triggered by a viral prodrome. Or it can be more aggressive in the setting of giant cell myocarditis. Now, just to touch on treatment, so what are the goals for early treatment for cardiac sarcoid? And I think they're threefold. So you want to decrease inflammation, right? Prevent fibrosis. Basically, we want to prevent potentially irreversible fibrosis. And of course, all the downhill sequelae, which is like adverse LV remodeling. We want to preserve cardiac function, and then of course, reduce sudden cardiac death risk associated with these abnormalities or ventricular arrhythmias. The treatment can be divided into two categories. So treatment of inflammation, and then clinical sequelae, so the arrhythmias and the ventricular dysfunction. Now, among the anti-inflammatory agents, steroids or glucocorticoids are usually considered the first-line therapy. But keep in mind that there's no randomized control study that has systematically evaluated their efficacy or their ideal dosing, treatment duration. So again, the management is highly empiric and based on centers of excellence and their cases that they see. Most experts recommend an initial dose of 30 to 40 milligrams of prednisone, followed by repeat imaging after 1 to 6 months. And again, there's limited data to timing of de-escalation or dosage and the overall duration. But I think the bottom line here is that the earlier the treatment, the better the diagnosis or the response. I apologize. Now, this is an image-guided approach for immunosuppressive therapy because, as I mentioned, there's limited data to timing of dosage de-escalation and overall duration of steroid therapy. There's a decision treatment algorithm. So this has been proposed and it's often used in clinical practice. So as I mentioned, if you start at the top, you're starting your prednisone, repeating your PET scan perhaps after 3 months of treatment, seeing if there is abnormal FDG uptake at that time, and if there is, then you're adding another agent, or if there's not, then perhaps you're tapering and then following up in 3 to 6 months to see what the disease process is like. Now, steroid-sparing alternatives or anti-metabolites are considered second-line agents, and this should make sense because often cardiac sarcoid patients require years of therapy, so the use of these steroid-sparing agents would be beneficial instead of prolonged steroid use. Methotrexate has the most supportive evidence, as athioprine and mycophenolate have been reported as effective in treating cardiac sarcoid patients, but there's little to indicate that either of these drugs is superior. And then as such, again, the choice for the individual patient would depend mostly on other factors and including provider experience. Third line therapy would be with biologics. Infliximab has been proved to be an effective treatment for pulmonary and neurologic sarcoid. Infliximab, rituximab, or corticotrophin have been used successfully, again, in some cases. Keep in mind, though, that increased mortality associated with the use of anti-TNF therapy in patients with severe cardiomyopathy, so we have to be careful. Rituximab has also been used in cardiac sarcoid in some cases. With this, it's also been proven useful in pulmonary and ocular sarcoid. And compared to other agents, there's no associated cardiotoxicity here. There is a longer latency to demonstrate benefit, and it's reported to be less effective than infliximab. And then cardiac devices, which also make up an important treatment algorithm, a part of the treatment algorithm. So it's important to treat the underlying arrhythmias, and these cardiac devices have become standard in symptomatic cardiac sarcoid. For patients with documented ventricular arrhythmias, especially VT or ventricular tachycardia, placement of an ICD, as you can imagine, can be life-saving. Now, for asymptomatic patients, if they lack classical triggers, you can do programmed electrical stimulation, EP studies for risk stratification. And of course, placement of an ICD can provide patients with a safety net, even when you're starting them on treatment, because keep in mind that arrhythmias still remain highly prevalent in the first few months. This is consensus recommendations for ICD implantation and cardiac sarcoid from HRS. So it kind of walks you through the class 1, 2A, 2B recommendations. At the top, just to briefly go over, if you have sustained arrhythmias, including prior cardiac arrest and or EF is less than 35, despite optimal medical therapy, being on immunosuppressions, ICD is recommended. And it kind of goes down the line. If there's unexplained syncope, inducible arrhythmias, ICD can be useful, class 2A. And then also, if the EF is greater than 35 and you have cardiac MR findings of perhaps a scar or an electro or an EP study that's showing you high risk arrhythmias, then an ICD may be considered class 2B. And just keep that in mind. It is in contrast to the AHA recommendations where there's a class 2A recommendation to consider ICD implantation in patients with EF of greater than 35% scar in an MR. So it kind of combines together when an ICD should be considered. Now, of course, at the same time, when we're considering all these steroids and antimetabolites, standard guideline-directed medical therapy for the management of heart failure should be initiated. Although these therapies perhaps do not have any effect on specifically the sarcoid activity, of course, it has beneficial effects on ejection fraction, remodeling, heart failure-related outcomes. Transplantation is usually considered down the line if there's intractable arrhythmias, end-stage heart failure. And there actually is a cardiac sarcoidosis randomized trial, CHASM, which is an international study looking at, or it's obtaining data for treatment of CS. So it's enrolling subjects and randomizing them to standard prednisone for 6 months or a combination of methotrexate and prednisone. The study started in January of 2019, and the estimated completion date is actually in December of 2024. And just to kind of wrap things up here, so just knowing with all the nuances and the caveats of cardiac sarcoid that we've talked about, as you can imagine, it's a complex disease process. It's combining genetic and perhaps likely environmental factors. There is an importance of centralizing cares and centers of excellence. There's a need to create international consortia, right? We want shared goals and protocols and imaging strategies. And so we can continue to learn more about this and get ahead of it. There's still a need to define specific molecular pathways and targeting therapies. And ultimately, our goal is to attain a better understanding of the disease pathophysiology and standardized treatment for these patients. All right, thank you.
This is Karthik Anand. That I'll just make a few comments. I know we're on a timeline here. Lindsay, just a fantastic review. It's a tough topic to review, but you did a phenomenal job. I just have a few comments just to reiterate, just from practicality aspect. Lindsay has touched on everything. Number one is, when do you actually get advanced imaging? I know Lindsay actually did go through this. I'm just going to share one slide, very simple slide, kind of what the Heart Rhythm Society recommends, which I think is very reasonable, and Lindsay touched on this, is particularly if you're searching for cardiac sarcoid, but the patient, the key thing is to start with the fundamentals, as mentioned, history, ECG, and echo. And if those are completely normal and the patient doesn't have any symptoms, there's really not great justification in using advanced imaging. Obviously, because we underdiagnose this, you should have a low threshold to do additional imaging if any one of these are abnormal and the patient has symptoms. The one thing I would mention is I think we should do CMR and FDG PET as complementary rather than one or the other once we go down that path. And the simple reason being CMR doesn't pick up early inflammation as well as FDG PET, and FDG PET doesn't pick up minimal fibrosis as well as CMR. So I think both work hand in hand. Typically, if you have a completely normal CMR, unlikely to have cardiac sarcoid, except in some unique situations, for example, like BT or complete heart block. Those are a very high likelihood of isolated cardiac sarcoidosis in the right clinical setting. And then the only other thing I would mention before referring to PET is that a conclusive workup for obstructive coronary disease has to be done. If we do not rule out obstructive CAD, PET may become falsely abnormal because we can differentiate the FDG uptake between a hibernating zone of myocardium with ischemia versus for cardiac sarcoid. So FDG is not specific for sarcoid, it has to be put in the right clinical context, as Lindsay mentioned. And Lindsay, if you don't mind, I'm going to just stop sharing the slide. I just want to make one final point, is if you can share the Japanese Ministry of Health and Welfare criteria, please.
Yep, just 1 second.
I'm going to stop sharing right here.
Okay.
And it's important to note that in the absence of a clear biopsy diagnosis of sarcoid, I think what we can only say is there probable cardiac sarcoidosis or possible cardiac sarcoid? I think that's an important for shared decision making with the patient, is that the greater the abnormalities leading towards a sarcoid diagnosis, the better it is. But the guidelines themselves clearly say right there, if you look at the clinical diagnostic approach, if you don't have histological diagnosis, but you're only doing it by clinical diagnosis, it is a probability that there is cardiac sarcoidosis based upon a few things. I mean, histologically, if you're able to prove it, that's awesome. If not, I think it's only putting many things together leading to the likelihood that this is sarcoid. And I think arrhythmogenic RV cardiomyopathy or left dominant RV cardiomyopathy and sarcoid can actually mimic each other. So that's another area to be kind of highlighted when we kind of review these cases. So I'll stop there. If there's any questions, happy to kind of work with Lindsay and answer it. Great job, Lindsay.
Thank you.
Everybody hear me?
Yep, we can hear you.
Yeah, hey, great job, Lindsay. I agree. This is a very challenging topic, and especially when it's very difficult to diagnose these patients when there is no extracardiac sarcoidosis. And a lot of this monitoring and management is based on expert opinion. So the only other, the one question that came to my mind was, and Dr. Anand, thank you so much also. Is there any data on how often patients who have a normal MR end up having a positive cardiac PET afterwards, if they have it at the same time?
I do not know of any large studies, but at this particular point, I think, but if you look at registry data, and I've actually, I work closely with the Brigham Group and other things as part of Societal for Sarcoid and stuff. And in general, when we have a completely normal perfusion scan or a completely normal MRI, the likelihood is low unless you're facing active arrhythmic folks or like heart block folks. Those are the two high likelihood scenarios where we have seen that patients can actually have a completely normal MRI. And we have a patient actually in our institution, I think, and I'm taking care of one, and maybe Cody or Jen is taking care of the other, where the MRI was normal, but the PET scan was abnormal in the setting of complete heart block. So I think anybody with less than 60, particularly presenting with BT or complete heart block, with or without left ventricular dysfunction, I think those would be the group where I would say that MRI could be normal.
Makes sense. Thank you. Thanks again, Lindsay. All right, so
All right, hey everybody, can everybody hear me in here? That's good. All righty, can everybody hear me here? Cool. So my name is Sid Kanda. I'm actually staff in the Department of Dermatology. I actually one of our newly hired dermatology hospitalists. So I specialize in inpatient dermatology. I take about 50% of our call right now, so I'm on service quite a bit. And then as a consequence of that, I see a lot of these inpatient cases in follow-up. So I end up doing a lot of complex medical dermatology. It's going to be like vasculitis, bullous diseases, a lot of connective tissue diseases like lupus. Sarcoid gets on the list too, because some of our sarcoid patients, as you know, will be in the hospital for, as we just saw, lecture, cardiac sarcoid and other complications. So I'm going to be honest, when I've told some of my colleagues that I was giving this talk, I got a lot of puzzled looks and some laughs, because cutaneous sarcoidosis is truly one of the hardest things to diagnose. There are classic presentations, and I am going to go through those with everyone here. But the nickname that it has is the Great Mimicker. I'm sure you might have heard that, or the Great Masquerader. And the reason for that is some of the most experienced dermatologists in the country, we're talking people who have decades of experience, very well regarded, can miss this diagnosis just because it can present in so many different ways with so many different morphologies. That being said, I'm going to focus on those things that are most relevant to other specialties in terms of the most classic presentations, as well as the things that actually have prognostic relevance that can be correlated with systemic involvement and either be a good prognostic indicator or a negative prognostic indicator. Just found out I was muted, everyone who's listening. But you didn't miss too much. Long story short, sarcoid is very hard to diagnose, but we're going to do our best to get through it. So like I just said, cutaneous manifestations are seen up to 1/3 of patients. They may be the first or only clinical sign of disease. And like I said, I already talked about the goals. We're going to read some of those common presentations. Dr. Rohr already mentioned this a few times, but this is a diagnosis of exclusion, both clinically and histologically. In order to establish a diagnosis, you need a supportive clinical history, but you also want, ideally, histologic presence of non-casein granulomas in at least one organ system. The reason I kind of bolded and underlined that is because in a lot of situations, if we're talking about like pulmonary sarcoidosis or cardiac sarcoidosis, we're talking about doing endobronchial biopsies or cardiac biopsies. If we're talking about neurosarcoidosis, we're talking about doing a brain biopsy. If you have skin involvement and you can get those non-casein granulomas on the skin without having to do one of those procedures, that's a huge win for you, the patient, et cetera, especially if they have comorbidities that are making some of those more invasive procedures less than ideal. So moving on here. So for those patients with cutaneous sarcoidosis, in about 20% of patients, the skin lesions will actually precede systemic disease. In 50%, the skin and systemic lesions or systemic involvement will appear simultaneously. And in 30%, this one's actually kind of interesting. The skin lesions can appear up to 10 years after the systemic disease. And this often occurs as you're tapering off of the systemic steroids for their pulmonary involvement or some other cause. So basically you're masking the cutaneous involvement. And as you peel off of the steroids, they'll start to get new skin lesions. The skin lesions in general do not correlate with systemic involvement, with the exceptions I highlight here below: lupus pernio, subcutaneous sarcoidosis, and erythema nodosa. And we're going to go through each one of these one by one. So this is kind of the generic picture of cutaneous sarcoidosis. Most commonly presents as red, brown, or violaceous papules or plaques. However, skin manifestations are protean, meaning they can be any color, any shape, any size. This is just sort of a prototypical picture. This is directly from the dermatology Bible known as Bologna. This is sort of the preeminent textbook. And this is sort of a table showing how many different ways it can present. So I know I keep emphasizing this and I'm kind of a broken record, but it truly can present in almost any way. We're going to focus mainly on the common presentations, and I'll spend a little bit of time on the uncommon and rare, but I really want to focus on the common presentations. So the first thing you want to know is cutaneous sarcoidosis has a strong facial predilection. And that's important because I don't expect everyone in this room to get people in a gown and do a full body skin exam. It's not always reasonable given your time constraints and given your other competing priorities, but it is relatively easy to just take a look at their face because that's readily exposed. Obviously with masks, it's a little bit tricky now, but you can have them bring it down. They're usually symmetric in nature. They favor the nose, especially the nasal ala. I'm going to show plenty of pictures. And they also favor the periocular and perioral regions of the face, followed by the neck, upper trunk, and extremities. So the two things we're going to focus on right now are papules and lupus pernio. Lupus pernio, I'm going to show pictures of, but that is specifically when the papules and plaques are on the nose and the cheeks. That's why it got that misnomer. It's not lupus. But when it was diagnosed initially many, many years ago, they thought it was lupus because it has that same distribution of being the nose and kind of the medial cheeks. So here's an example of pretty subtle lupus pernio involving the nasal ala. You can kind of see a little bit of mild erythema here, some scaling. It looks non-specific, right? You could think like maybe it's just a little bit of irritation. So you have to have a high index of suspicion in these cases in order to sort of make that connection. If someone has pulmonary symptoms, like, okay, maybe you should get this biopsy, get this checked out. Here's a more robust example and a very classic example of lupus pernio. In particular, you can see that there are sort of papules coalescing into a line, kind of like a linear array along the nasal ala. That's kind of essentially, they call it a beating of the nasal ala. That is a classic sign of lupus pernio. Here's another example. Again, you can see prominent alar involvement. Again, it's kind of a recurring theme here. This is, again, a good example of lupus pernio. And you can see the color varies too, depending on skin type. In lighter skin types, it's going to be more pink and red, and darker skin types can be more violaceous, kind of a purple color. Here's another example of how it really, facial sarcoid really likes to go around orifices, whether it's going to be the nose, the mouth, the eyes. And here's a good example of perioral sarcoidosis, kind of these papules coalescing around the vermilion border there. Another good example, involvement of the vermilion. Kind of subtle, kind of hard to see, but they sometimes can coalesce into almost annular appearing round plaques as well when they are going around the perioral areas. And then periocular as well as another area. So like I said, periocular, perioral, nasal ala. I know I'm a broken record, but I'm just trying to get those points in because I really just want to focus on the stuff that's actually relevant to the other departments as when you're seeing these patients quickly. And then here are some other good examples of lupus pernio. This top right picture, you can see pretty severe involvement beating along the nasal ala. This is almost a nodular plaque at this point. And here you can kind of see how these patients may have been misdiagnosed as lupus at some point with that nasal involvement and medial cheek sparing the nasolabial fold, but this is all lupus pernio. This is actually sarcoidosis. Now, the reason I'm spending so much time on this particular presentation of lupus pernio is because this is one of the few cutaneous findings that actually has prognostic value. And in particular, these patients tend to have chronic sarcoidosis of the lungs that tends to be difficult to treat. This is going to be seen 75% of the time with lupus pernio. And they also tend to have upper respiratory tract involvement. So it's not just the lungs. We're talking about the trachea. We're talking about the pharynx. Like you can have involvement anywhere. You can sometimes have ulcerations, masses. They can actually be at risk of respiratory compromise. So this skin finding can really be a good indicator that you need to do a little bit more of an extensive evaluation. Here's another good classic example, lupus pernio, nasal ala involved all over again, kind of beaded papules. And here you can see a dramatic example. You can get almost rhinophymatous changes that look like rosacea. So this can get misdiagnosed sometimes. Like good dermatologists sometimes will think it's rosacea until things progress or things don't respond to rosacea treatments. One thing to know, when lupus pernio progresses to this extent, you can actually have an involvement of the septum, the cartilage. You can actually have collapse of the nasal the actual nasal structure entirely. So when you have severe lupus pernio, it's not a bad idea to just get an ENT eval to see, do we have any risk here of structural collapse or any sort of compromise here? The other thing to note is that lupus pernio can be associated with granulomas in the bones, most often in the fingers. It's also well correlated with ocular sarcoidosis. I know we're going to have a talk about ophthalmology later. And it also can have sinus involvement. So really check the face out with these patients. So key takeaways: in a patient with persistent respiratory symptoms or imaging findings suspicious for sarcoidosis, it's relatively easy to do a cursory skin exam of the face to see if there are any suspicious findings. We are always happy to see these patients do a biopsy if there's any concern whatsoever for sarcoid. And like I said, that can spare doing an invasive procedure. And yeah. And then moving on to another very common presentation of sarcoid that's easy to see or easy to check in your clinic is trauma-associated sarcoidosis. So this is going to be sites of prior injuries, such as scars or tattoos. This is another classic finding in cutaneous sarcoidosis. Here are some examples of just non-specific papules within a tattoo. Most often the dyes are going to be sort of red and yellow, but it can be seen with any tattoo dyes. One thing I didn't want to harp on too much is that the differential diagnosis in these situations is going to be foreign body reactions to the tattoo dyes themselves. And there's a lot of controversy where in the past they used to say if you biopsy and you get granulomas and there's tattoo dye in the granulomas, that's just a foreign body, it can't be sarcoid. They've done a lot of studies since then that have shown that the two processes are not necessarily that clear cut. You can have sarcoidal reactions to tattoo dyes as well. But definitely tattoo reactions and associated sarcoidosis are a known finding. Here's another example within the tattoo, some sort of non-specific violations appearing papules. Another example here, red-brown coloration. And then here's an example of scar sarcoidosis. So this can occur literally months to years after the initial insult. And as the sarcoidosis is actually becoming active, let's say pulmonary sarcoidosis, you can start to see changes in scars that have been pre-existing. And the reason I mention this at all is because it's extremely easy just in a quick exam to just ask a patient, like, do you have any tattoos? Do you have any scars? Have you noticed any changes recently? That can set off an indicator in your mind as well. You do have to ask that because patients will almost never think it's related to whatever systemic findings they might have. And the other thing I want to mention is if they have a tattoo in a place that's not readily observed, like let's say their back or something, they might not even know things are changing because cutaneous sarcoid more often than not is asymptomatic. Only 10 to 15% of the time is it actually itchy or painful, unless you have like structural destruction of the nose or something like that. So you have to have your index of suspicion for tattoo and scar related sarcoid. Okay, and then in terms of the last sort of common presentation of sarcoid, at least per the primary resource in dermatology, they kind of just say plaques of the trunk and extremities, which if you have any experience in dermatology, it's the most broad and vague term you can imagine. Plaques is just anything greater than a centimeter that's raised, and that can be almost anything. So I'm going to show you some pictures of what this could look like, just so you know the range of possibilities that will set off the kind of trigger to think like, okay, this could be sarcoid. Let's just get this checked out. Let's get this biopsy. So here's an example of sort of red-brown hyperpigmented plaques. Some of these are a little bit scaly on the arm here. You can also get pink to violaceous plaques. This can kind of mimic lichen planus. I don't know if you guys have seen lichen planus in real life, but you probably have to study it for step one, where you get the purple polygonal flat top papules associated with hepatitis. And here you could really kind of imagine for this to be lichen planus, but this is another example of sarcoid mimicking another condition. Here's just kind of a background or a more of an overview picture of what these lesions can look like on the trunk. They can be ill-defined, just sort of subcutaneous, hyperpigmented plaques, very non-specific. And then here's sort of pink annular appearing lesions. Like I said, you're kind of seeing, again, depending on the skin type, the color will differ significantly. Pink and red and light types, or lighter skin types, and violaceous and darker skin types. This could very easily be misdiagnosed by sort of like a widespread tinea corporis or a granuloma annulare or something like that. Again, another example of how this can mimic other conditions. This is actually sarcoid as well. This is on an elbow. Any reasonable dermatologist seeing this in their practice would think this is psoriasis. That would be their first guess. So you have to have a high index of suspicion in these cases to actually go ahead and do the biopsy and make sure you're not missing the diagnosis. And then here's one I really want to emphasize, because this is, again, one of the few situations where it does correlate with systemic involvement. This is called subcutaneous sarcoidosis. There's the actual moniker for it is Derrier-Rousset. And essentially, it's where you get asymptomatic nodules underneath the skin. They're going to seem like lipomas or epidermoid cysts or just something kind of rubbery or non-specific. But the patient will say that they kind of came on relatively quickly, and they tend to form almost linear cords on the arms. The reason this is involvement is because this is, again, one of the forms of cutaneous sarcoid that is a harbinger for systemic involvement. So again, a good prognostic thing to know about. So key takeaways here: sarcoidal plaques on the trunk can really look like almost anything, but subcutaneous sarcoidosis is concerning for systemic involvement. And just to emphasize again, subcutaneous sarcoidosis, that essentially means that there are no overlying skin changes. You're not seeing a color change, a scale change, or anything, or like scaling or ulceration, anything like that. The last sort of really important finding I want to mention is erythema nodosum, which I think everybody in the room is familiar with for one reason or another. This is important to know that it's a non-specific cutaneous manifestation of sarcoid, and it's kind of a subtle difference between specific and non-specific. The reason it's called non-specific is because erythema nodosum can be seen in a variety of clinical scenarios, not just sarcoidosis. It can be seen with other connective tissue disease. It can be pregnancy related. It can be medication related. It can be seen with streptococcal infections. So just because you see erythema nodosum, it does not necessarily mean they have sarcoidosis. The other thing to note is if you refer a patient for biopsy of erythema nodosum, that biopsy will reveal erythema nodosum, but it will not make the diagnosis of sarcoidosis. This is one of the few situations where a skin biopsy can give you some evidence, but it's not going to get you to that non-caseating granuloma that you're hoping for. The reason this is important to know is not just for the biopsy purposes, but it's also an excellent prognostic indicator as far as sarcoidosis goes. It's generally associated with subacute transient sarcoidosis that resolves spontaneously, typically does not need systemic corticosteroid therapy. The one exception is something called Lofgren syndrome, which is more of an acute presentation where you have fever, you can have arthritis, typically of the lower extremities, usually the ankles, hyaluronitis, uveitis, and erythema nodosum comes on very quickly. Those patients sometimes do need NSAIDs and steroids to try to calm things down, but generally the prognosis is good, tends to resolve over a span of months to usually 2 years at the most in the majority of patients. So here's a good example of what erythema nodosum looks like. You get these sort of ill-defined erythematous tender nodules and plaques, most commonly seen in a pretibial distribution. That's the most common location. When it's extremely active, you can get involvement of other sites of the body, but you're almost never gonna get a situation where you don't have pretibial involvement, which is why we emphasize the pretibial area so much. Just a couple of brief points on pathology. I know that like none of us in here are the ones reading these biopsies on the regular, but it's just good to know some of these things. Just when you're doing a biopsy to have a framework for what kind of results you might get. So I already emphasized the difference between specific and non-specific skin involvement, meaning that with specific lesions, that gives you a chance of getting a non-casing granulomas. With non-specific skin lesion like erythema nodosum, these are more secondary skin findings that won't necessarily get you to the diagnosis. Some of the other secondary skin findings, one is calcinosis cutis, where you actually get calcium deposits in the skin. And the reason for that is anytime you have widespread granulomatous inflammation, as you do with sarcoidosis, there's actually enzymes within the actual macrophages that convert vitamin D to its active form. So you get hypercalcemia, hypercalciuria, and the hypercalcemia is what leads to the calcinosis cutis. So it's sort of a secondary finding. You can get eczema, erythema multiforme, itching, things like that, which are all just non-specific. Now, the goal obviously is to identify these sort of beautiful non-caseating epithelioid granulomas. They're called naked tubercles because if you look, the granulomas are super well circumscribed. And I know it's pretty hard to see, but in between the granulomas, there's not much inflammation at all. It's kind of just dermis with a couple cells here and there. And unless you've done a ton of pathology, that's probably not really making a lot of sense. But long story short, there are situations where you can get really dense lymphocytic inflammation in between the granulomas as well. And there used to be a school of thought that, okay, if you have lymphocytic inflammation in between the granulomas, it can't be sarcoidosis. In the real world, in real life, it's a spectrum. Just like with every system we're going to talk about today, sarcoidosis pathology can really be a spectrum. So a lot of times you'll have to have a conversation with your pathologist. If you have sort of indeterminate findings, you have to put your minds together as a clinical and a histologic, and you have to talk, you have to communicate. Treatment, I'll just touch upon very quickly because I think every lecture today is going to talk a little bit about treatment. From a derm perspective, I know it's very stereotyped, but we do start with topical steroids. However, if things are very severe, let's for example, we have pretty bad lupus perennial, we might do some ILK to those areas to try to prevent progression because like I said, that can progress, it can lead to structural destruction. And then we do usually defer systemic treatment to treating the pulmonary manifestations or the cardiac manifestations, the ophthalmology manifestations, and neurology manifestations. But if we're dealing with sort of widespread cutaneous sarcoidosis without severe systemic involvement, we actually will do systemic therapies as well. can include plaquenil, chloroquine, minocycline, methotrexate, thalidomide. We also do sometimes use infliximab and adalimumab for widespread cutaneous involvement. The one thing I want to mention, which I don't know if it's already been mentioned, TNF alpha inhibitors, there's a love-hate relationship with them, because if you know a lot about TNF alpha, so you can get paradoxical reactions with these medications. There's one thing called TNF alpha induced paradoxical psoriasiform eruption. So these treatments are used to treat psoriasis, but you'll see sometimes you'll use these treatments in patients for something else like rheumatoid arthritis, and then they'll develop psoriasis as a consequence. It's a paradoxical eruption. The same thing happens with sarcoidosis. So you might have a patient who has already been on a TNF alpha for some other condition who then starts to develop sarcoidosis. That should really set off an alarm for, is the TNF alpha actually responsible for this eruption? So key takeaways, I'm kind of finishing up here. Skin findings are relatively common in the setting of sarcoid, but manifestations are protean, difficult to diagnose. Again, these are the three things I want you guys to focus on, the big takeaways. Lupus pernio, so that's going to be involvement of the nasal ala, central face, highly concerning for systemic involvement. Subcutaneous sarcoid, meaning kind of nodules underneath the skin without any overlying skin changes, also concerning for systemic involvement. Erythema nodosum, which are going to be the nodules on the shins, that's a good prognostic indicator, really promising in terms of resolution in a couple of years. You want to ask patients if they have any scars or tattoos that are changing that can be suspicious for cutaneous sarcoid. If you see anything on the patient's skin that you can't explain that's brand new and you're evaluating for some systemic sarcoid, we're happy to check it out in our clinic, do a biopsy if needed. And like I said, that can help avert more invasive procedures. And systemic therapies are usually directed towards control of internal manifestations. Now, I included some bonus images. I'm going to literally fly through these in 1 minute so we can get us back on time here. But just to show you how ridiculously varied these presentations can be. So we're going to go into some of the rare pictures now in this last category here. You can get sort of micropapular sarcoid, which literally this differential would be massive. It would be very difficult to make the diagnosis of sarcoid. Here's another example of papular sarcoid. You can get alopecia on the scalp, which is actually, it's considered rare, but I've seen it a handful of times now in real practice. So if you have a sarcoid patient talking about new onset hair loss, something to think about. You can sometimes have almost like a psoriasiform plaque, but sometimes it's just hair loss without any background changes. You can get erythrodermic sarcoid, which we actually have seen in our clinic. Dr. Lim, our former chair, actually has at least one, maybe multiple of these patients. You can get ichthyosiform sarcoid. So I don't know if you heard of something called ichthyosis vulgaris, where it just looks like kind of the colloquial way to describe it is just fish scaling on the legs. There's a genetic reason for it. And a lot of times you just treat them with emollients, just dry skin. But unfortunately, sarcoid can present like that too. You can get ulcerative sarcoidosis, or just lesions all over on the lower extremities. You can see here in the bottom left on the I guess patient's right lower extremity, a huge ulceration. We have seen this in real life in real patients, I promise. And then here's a very interesting example of what's called hypopigmented sarcoid. Subtle, but you can see these kind of round hypopigmented areas. You could maybe imagine someone's calling us early vitiligo or something like that. It would not be unreasonable unless you had a high index of suspicion. Digital sarcoid, you can get fusiform digit swelling. You can get nodules on the digits. You can get ulcerative lesions and annular lesions along genitalia. So it's a scary world out there. So if you have any suspicious lesions, just let us know and we'll check it out. If you have any questions, you can ask me now. You can send me an email. I do kind of enjoy complex med derm, so feel free to reach out to me. We do have multiple other very good medical dermatologists in the department who enjoy dealing with some of these more complex cases, okay? If there's any questions, feel free to put them in the chat or ask. And yeah. That's a good question. So one of the questions from the audience was, could trauma-associated sarcoidosis be considered pathergy? And I think that there's, so pathergy, for anybody who doesn't know, pathergy essentially when you traumatize the skin, it kind of leads to development of a pathology at that site, typically seen with the neutrophilic dermatoses like pyoderma gangrenosum and things like that. With pathergy, typically it's going to happen relatively quickly. We're talking about like days to weeks. With scar sarcoidosis, the time span can be months to years. So I don't know if I necessarily call it pathergy. I don't think that's the wrong way to think about it, but it hasn't really been described that way within the dermatology literature, just because the time course can be so delayed in terms of how it presents.
Maybe like a follow-up to that is probably, I don't know if this is an answer, but
yeah.
you typically see it where they would have systemic disease disease, or would you just see this in the scar and that's their only manifestation of sarcoid?
It's a good question. So another question was with trauma-associated sarcoid, for example, tattoos or scars, is this typically going to be the only manifestation of the disease, or could there be systemic involvement? So unfortunately, in the literature, they have not shown, well, I guess fortunately, they have not shown a strong correlation with systemic disease. The only ones that have shown a definite increase in systemic disease are going to be the lupus pernio and the subcutaneous sarcoid, but they haven't seen a correlation with trauma associated.
I think what you mentioned earlier is really important in that we see patients who have evidence of pulmonary sarcoid. And I think for everybody in here to know at least some of the common presentations and ask the questions about the stomach is really important. Because what you said is what I have been saying for a long time. The easiest biopsy to get is a skin lesion. So if you see somebody with a lesion, you think it's sarcoid, you need to first.
Agreed. There's just one more comment from the audience, which I agree with wholeheartedly, and I'm going to emphasize one more time, is the skin is truly the easiest site to access for biopsy compared to all these other organ systems. So it is good to ask these questions. It is good to be a little bit thorough in your examination, even though I know everybody likes to focus on their own system. Trust me, I like to focus just on the skin. There are situations where it can really save the patient a lot of morbidity and also get the diagnosis a lot faster sometimes too. Okay, thanks for your time.
Can you hear me? Or should I take my mask off? Just goes, right? So you can hear me, right? Okay. I'm Mirala Cherget. I'm from neurology, and I'm gonna present the neurosarcoidosis part. So I have no financial disclosure for this lecture. I'm gonna talk about manifestation of neurological manifestation of sarcoidosis, the diagnosis of neurosarcoidosis and treatment of neurosarcoidosis. So historically, in the literature, it's suggested that 10 to 15% of patients with sarcoidosis will develop a neurological disease. However, it seems that post-mortem data shows that CNS is involved more than the 10, 15% that we clinically see. And also from literature, we know that the neurological involvement can precede the diagnosis of systemic sarcoidosis, maybe in the 50 to 74% of cases. And maybe 75% of patients with systemic sarcoidosis who develop neurosarcoidosis will do so in the first 2 years of diagnosis of systemic sarcoidosis. I needed to take this with great assault. Epidemiological studies of neurosarcoidosis are very difficult. First, we don't have really a diagnosis test for neurosarcoidosis. It's not a frequent disease. Could be asymptomatic cases, and what we know is mostly from case reports. So maybe this data on 50 to 74% actually is taken from neurological cases, so patients seen in neurology clinic. And there is so-called isolated neurosarcoidosis, where there is no systemic involvement. This is reported to be 17% of cases with neurosarcoidosis. We heard that sarcoidosis is the great mimicker. I guess it's the same in neurology. And in neurology, it can affect almost anything in the nervous system. It can involve the cranial nerves, it can involve the brain, meninges, it can involve the peripheral nerve, it can involve the spinal cord and the muscles. So let's start with the cranial nerves. We know that granuloma can infiltrate the cranial nerve nuclei, so in the brain, the fascicles and the nerves, and will produce cranial neuropathy. Typically, it's a subacute course, and more than 80% will have other neurological manifestation. And when we look at the MRI, a lot of time we see already leptomeningeal enhancement in patients with cranial nerves. The most common reported cranial nerves are the facial nerve and the optic nerve. There are case reports over the years, and the percentage of patients with cranial nerve involvement is anywhere between 20 to probably 40%, depend on the cohort and the case study. There is maybe the first report of facial nerve palsy from Herford, who described a patient with parotid enlargement, uveitis, and facial palsy. I believe he initially saw that's related to mumps, and later on Waldenstrom called it Herford syndrome and link it to sarcoidosis. Central nervous system, so we have parenchymal involvement due to granuloma infiltration, but also there is a vascular involvement or inflammation in the vessels. The clinical symptoms that patient presents are varied. It depends where it's localized in the central nervous system. It depends how big the lesion is. Patient can present with focal neurological symptoms, with weakness, with numbness. They can present with ataxia. They can present with seizure, headache. As MRI, we see different manifestation of neurosarcoidosis. Patients can have T2 hyperintensities, which are gadolinium enhancing when there is active neurosarcoidosis, and you can see here a little bit, or in the brainstem. Those findings are non-specific. They can be seen in other autoimmune or inflammatory neurological disorder. It can mimic multiple sclerosis, or again, other autoimmune CNS disorders. Sometimes can look like a tumor, and here is an example. You can see the enhancement and the edema surrounding that lesion, or it can look like meningioma, round, very well detailed, and you can even see in meningioma there is a dural tail. This one most likely is just a meningeal enhancement, but can look like meningioma. In neurosarcoidosis, the veins can be inflamed, so it could be a vasculitis, a venulitis, the veins, or people can have venous sinus thrombosis that can further lead to hemorrhagic strokes. So it's very, very rare reported reports of stroke or hemorrhagic strokes, but they are reported. And one needs to be very careful because patients with sarcoidosis, at least what we usually see in neurology, are elderly, or I shouldn't say elderly, but over 40. And they can have multiple reasons to have strokes, either ischemic or hemorrhagic strokes. So one needs to be very careful looking at those manifestations. The pituitary can be involved in neurosarcoidosis. There is a neuroendocrine dysfunction, which is listed about 10 to 20% of patients with sarcoidosis. And the most common is involved the anterior hypothalamus. Clinical presentation can range from panhypopituitaris to selective dysfunction of either anterior or posterior pituitary gland. On MRI, what we see either a thickening or a contrast enhancement of pituitary gland, or the stalk can be thickened and enhanced. Meninges can be involved and could be either pachy or leptomeninges. It leads to aseptic meningitis, which is most common presentation of meningeal involvement. But this leptomeningeal disease can lead to cranial nerve dysfunction and can lead to hydrocephalus from obstruction of CSF flow, as you can see in the lower MRIs. And here you can see the leptomeningeal enhancement that sometimes goes actually down on the spinal cord. The sarcoidosis leptomeningeal disease has a predilection for skull base. So it's very similar actually with tuberculosis, which also has a predilection for skull base. Spinal cord, historically, there are rare reports of spinal cord involvement. However, the more contemporary studies show the prevalent incidence of maybe 20 to 30% of patients with sarcoidosis or with neurosarcoidosis. And it's due to infiltration of granuloma in the spinal cord parenchyma in leptomeninges, but sometimes it can be an infiltrate of the structures around spinal cord and cause compression and further neurological symptoms. So how do they present? They present with numbness, with tingling, with neuropathic pain, or weakness in extremities. On MRI, we see a different presentation. It could be a focal myelitis. I don't know if you can see it, but it's very small lesion there in the spinal cord. It can be a long lesion. We call it longitudinal extensive myelitis, or it could be the meninges or the nerves and some meningoradiculitis. Those are not specific for sarcoidosis, none of them. They can have many other explanations. We did a study here at Henry Ford. We look at our patients from 1995 to 2019, and in our spine patients that we've seen in the clinic, majority had actually an extensive longitudinal myelitis followed by the leptomeningeal disease. Moving to peripheral nerve, both the small and large fiber can be affected by sarcoidosis. Could be sensory, could be motor, or could be sensory motor nerves affected. The most common presentation is a asymmetric or chronic peripheral neuropathy, which is mixed sensory and motor. Peripheral neuropathy can also be seen somewhere in between 10 to 25% of cases. Asymmetric peripheral neuropathy can be seen by can have other reasons in sarcoidosis patients because they, maybe the most common is actually diabetes, that it's a comorbidity with some of the sarcoidosis patients, especially on long-term steroid treatment. The best to demonstrate that disease related to sarcoidosis will be a biopsy of the nerve and see the granulomatous infiltration. Sometimes peripheral nerve can be affected asymmetrical and could be due to vasculitic process of the nerve, so-called the mononeuritis multiplex. Small fibers can also be affected, can be reported in patients with sarcoidosis. Contemporary studies actually consider it as a paraneurosarcoidosis manifestation because there is no clear evidence that is direct related to granuloma infiltration. Muscle can also be affected, and sometimes it's a combination of muscle and nerve. Muscle affected by sarcoidosis, again, somewhere between 10 to 20%. The common presentation is with myalgia, weakness of the limbs, and could be symmetric or could be asymmetric presentation. More recent study divided 4 patterns of muscle disease, so-called nodular, where a patient had bivalvation nodules, but they did not have any weakness. Smoldering, patients presenting with myalgia, but no evidence on clinical examination of muscle disease. Myopathic, where there is weakness associated, and combined myopathic and neurogenic pattern that can be seen on EMG. So when we have a patient that we suspect neurosarcoidosis, we have some tests that we can do, and they are not specific on neurosarcoidosis, and they are more important to exclude any other cause. So in serum, we look as usual for different infections, inflammation, base elevation, markers of inflammation. Patients, most of them will have a spinal tap, and again, in spinal tap, we look to see if there are markers of inflammation, for example, elevated protein or white cells, IgG in the CSF, IgG index, oligoclonal bands, but we also want to exclude everything that we can. Ideally would be to get a biopsy for diagnosis, but that's not possible in most cases with neurosarcoidosis. So we really have to look for systemic evaluation for sarcoidosis. And we've heard about the skin, lung. So what do we see as abnormality in CSF? We can see some elevation in protein, and those are percentage from different neuro cases reported in literature. Elevated white cells, and it's a lymphocytic predominance in neurosarcoidosis. Glucose can be low, and it's one of the few reasons for low glucose besides the infection. Elevated ACE is really non-specific, and we don't see it commonly elevated in neurosarcoidosis. Oligoclonal bands, those are markers of inflammations, meaning inflammation directly in the central nervous system when oligoclonal bands are present in CSF, but not in serum. And in the serum, again, SAD rate, CRP, or ACE could be elevated, again, non-specific. There was a 2019 study that looked at IL-2R. A marker of inflammation is non-specific. As far as I know, we can see it in other inflammatory disorder like IgG4 disorders, but it seems that it had maybe a better sensitivity and specificity profile than a serum ACE. When we look at our Henry Ford patients, majority were women, were African American. The median age of presentation with neurological symptoms was 48. And in the laboratory data, they had elevated CRP, ACE, SAD rate. It seems that African American are more likely to have elevated SAD rate than Caucasian with neurosarcoidosis. And in CSF, again, the same non-specific findings with gliocytosis or elevated protein. And in our cohort, again, the white cell count was more likely to be elevated in African American and Caucasian with neurosarcoidosis. As clinical presentation, it's very similar with what is reported in our literature. In our patients, 50% had a brain involvement, 30% had cranial nerves, 30% spine disease, and rarely a peripheral or a muscle disease. So diagnosis, again, the most important for diagnosis will be a biopsy, since this is a pathological diagnosis. This is not possible in most of the cases with neurosarcoidosis because of the potential comorbidities with procedure. So diagnosis classification for neurosarcoidosis was used for many years, was Stasi-Czech classification, and he reported that neurosarcoid patients with a clinical presentation suggestive of neurosarcoidosis, after other causes are excluded, if they have positive CNS histology, they are classified as definitive neurosarcoidosis. Probable when patients with neurological presentation have laboratory evidence of CNS inflammation, and there is evidence of systemic sarcoidosis. And possible when patients are highly suspicious for neurosarcoidosis, but there is actually no evidence of systemic sarcoidosis. There is a huge differential diagnosis of neurosarcoidosis. Clinical neurological presentation and MRI findings, all of them can be seen in many other neurological disorders due to infection, inflammation, tumors, vascular disease. So there is an update of neurosarcoidosis diagnosis from 2018, where a consortium made a recommendation, and they were approved by a World Organization of Sarcoidosis and other granulomatous disorders, and was divided as definite neurosarcoidosis when the clinical presentation and diagnosis evaluation suggest neurosarcoidosis by clinical manifestation, MRI findings, spinal fluid, and depending on presentation may require EMG or nerve conduction studies. And there is nervous system pathology consistent with neurosarcoidosis, and was divided as extraneural sarcoidosis is evident or no extraneural sarcoidosis is evident, so called isolated CNS sarcoidosis. Probable where the presentation is suggestive of neurosarcoidosis, similar with the first one, but there is pathology confirmation of sarcoidosis outside of central nervous system. And possible where presentation is suggestive of neurosarcoidosis, there are no other explanation, but we could not obtain any pathological confirmation. As a clinical course of neurosarcoidosis, this one also can vary. Some people can have a monophasic acute presentation, others can have a relapsing remitting phase or a chronic progressive phase. Cranial nerve neuropathy and mostly the facial palsy could be an acute or just a monophasic form, or a meningeal form can be a monophasic disease, but mostly the brain or spine forms, they have more a subacute chronic course. A very old study of neurosarcoidosis reported a third of patients experience of progressive course. And more recently, there was a 2017 study of 200, almost 300 patients, which is big for neurosarcoidosis. Most of the case reports less than 100 patients. But with this study, they showed that the 10-year survival rate was 89%, and mortality was associated with age, peripheral nervous system involvement, and the high baseline disability status. And brain involvement is associated with the higher risk of neurological relapse. When we look at our patients, they pretty much fall in the same forms as reported in literature. So neurosarcoidosis treatment, as for any other organ sarcoidosis, the goal is to prevent the damage of the organ, basically, and to treat to maybe improve the clinical manifestations. We have some issues with neurosarcoidosis treatment because there is no controlled clinical trials in neurosarcoidosis, and the treatment usually is based on case reports. More neurological presentation is variable, and the treatment is going to vary. So there are forms that they are more severe than others. For example, the spinal cord, the optic nerve can have poorer prognosis than a facial nerve palsy. We don't know the duration of neurosarcoidosis treatment, but it's clear that it's going to be months to years. Steroid-sparing agents can take months to achieve full effect, and there is no standardized testing for monitoring the response to treatment in neurosarcoidosis. So we have the acute treatment when initially the patient presents, and if they have severe presentation, usually spinal cord or brain, the treatment is with IV solumetrol for 3 to 5 days. That's followed by a prolonged oral glucocorticoid taper. If it's less severe, we can just start with prednisone and then monitor clinical and imaging findings. And once those stabilize and improve, then slowly taper down the steroid. But most of the patients with neurosarcoidosis, they do require long-term treatment. Some cannot tolerate steroids, some are refractory to steroids, some experience recurrence of the disease. And there are many options, I'll tell you later, but they are pretty much the same for any sarcoidosis organ. And the other part important in neurosarcoidosis is treatment of the symptoms to help patients with their chronic symptoms of neuropathic pain, spasticity, headache, and a lot of them requires rehabilitation. So steroid-sparing medication, the same as was presented earlier for cardiac sarcoidosis. There are many treatments. There is no clinical trial in neurosarcoidosis. There is no comparison except for case studies. So in case studies in 2016, it was reported that methotrexate is probably more beneficial than mycophenolate in neurosarcoidosis. In 2017, a study reported there was less relapses with methotrexate, cyclophosphamide, infliximab, comparing to mycophenolate for neurosarcoidosis. And a more recent study, I believe was in 2020, it was 28 patients with neurosarcoidosis treated with infliximab. It showed a clinical improvement in 77 to 90% of patients and 80% improvement in MRI findings. So we know about steroid-sparing treatments. 2021 actually review proposed a step treatment in neurosarcoidosis, but I think it's more important to look at the patient and decide from other perspectives, other comorbidities that patient may have, depending on the severity of presentation of neurosarcoidosis, potential side effects of medication, patient preference at the end if they decide on if they want an oral or an injectable, and insurance. No, let's not forget about that. How do we measure the response? Well, we don't have any standardized testing. We have no biomarkers. So we look at clinical response, and we'd like to see improvement or at least stability of neurological symptoms and neurological examination. On MRI, might be a little bit easier. We want to see that enhancement, inflammation is remitted. It's not there anymore. And sometimes we need to use spinal tap, which no patient likes to have another spinal tap, but could be helpful in a patient who's stable clinically, whose MRI is improved, and we consider to taper or stop immunosuppression. But can be also helpful in patients who have worsening of neurological symptoms, and there is concern of infection in context of chronic immunosuppressant treatment. So a little bit about cohort. We look at, again, of African American and Caucasian. Almost all of them were on steroids, and then we use different steroid-sparing medication. Mostly was methotrexate. Our cohort was from 1995, so we more recently started to have them on infliximab, so that might be why it's this difference there. But when we look at them, there was no difference in disability between African American and Caucasian patients with neurosarcoidosis. No really difference in improvement. The only difference that we found was that the MRI findings have resolved quicker in Caucasian than in African American. And when we look at the MRI, how long it will take for MRI to have improvement, it takes many, many months, somewhere about 80, 90 months actually of treatment if with immunosuppressant. So take home messages. In conclusion, neurosarcoidosis can be seen in 10 to 15% of patients with sarcoidosis, but maybe higher. A diagnosis of neurosarcoidosis is not easy to reach since there are no specific clinical findings, no specific radiological findings, not to mention laboratory. And the biopsy of CNS is really an aggressive procedure. We still have questions about treatment of neurosarcoidosis, but it consists of corticosteroids and then add-on steroid-sparing immunosuppressant. And currently, as far as I know, there are no FDA-approved drugs for treatment of sarcoidosis, nor really guidelines for how long to treat and take them and when can we take them off immunosuppressants. Most of the time, however, most of the time we know that in neurosarcoidosis, it is required a long-term immunosuppression. So I think that's it. Thank you. Hope I'm on time.
A question. So I know we don't have the guys. When do we take them off? When do you start to consider?
So once they are stable for at least a year, meaning stable clinically, no relapses, and there is no enhancement on MRI, then we start talking about tapering and taking them off. With the MRI, you have to remember T2 lesion, so-called, we call them non-specific, can be seen in everyone. So those are not actually considered active neurosarcoidosis.
I have another question too, because it was interesting in our cohort that, really most of our patients are African American, 15% are going to have resolution. And to me, it would make me think like, well, when we start them on systemic steroids, should we be starting them on a steroid sparing agent at the same time?
So for neurosarcoidosis, that's what we do, unless they come with a Bell's palsy or something really not severe presentation. But when they come with the brain enhancing lesion, when they come in the spine, cord enhancing lesion, we usually start both in the same time. Of course, after we get at least from somewhere outside of central nervous system of a pathological sample that it is sarcoidosis. It's complicated when we don't have anything to biopsy, and then again, all these MRIs, all these symptoms could be from other reasons.
One of the things that I think is important with the patients that we've shared with you, that I've shared with others, is that I think that it's really important, especially if we're going to use toxic drugs, to identify that the patients in fact have that diagnosis.
I agree.
And I would encourage everybody to remember in the room that if somebody has a stage 0 scattings or chest X-ray, normal chest X-ray, transbronchial biopsies are positive for 40% of patients with sarcoid. They just have something like lymph nodes is much higher. And I've had patients this year from your clinic who you guys thought had neurosarcoid but hadn't had any other manifestations, who had small non-specific mediastinal adenopathy where we were able to confirm the diagnosis of bronchoscopy. So don't be afraid to refer these patients to confirm the diagnosis before you start therapy with a lung biopsy. I think that's something that I've done.
Yeah, you're right. Without the diagnosis outside of central nervous system, it's hard. You cannot even order certain medication like infliximab. You need a diagnosis, and then you end up with a patient having so many neurological manifestations. You keep him on steroids and keep him because he doesn't know where to go. So it's really important to exclude even sarcoidosis if that's not the case.
Just along the lines of patients that do have resolution, there are also some that they have uncontrolled disease long enough, just like in pulmonary or even cardiac, without treatment, it leads to scarring. Do you ever see, or in your experience or the data, you see some that just are past the point of treatment or refractory of permanent nerve damage?
Well, with nervous system, if they do have, when they have a lesion, that lesion, it can leave permanent damage. That doesn't mean active sarcoidosis. They can have disability, they can have weakness, let's say an arm or leg, that could be forever. Even if we treat, we control sarcoidosis, we take them off immunosuppressant, they will still have symptoms. You cannot take away a lot of symptoms because the scar is there, but that doesn't mean active sarcoidosis. So it's a discrepancy in a way between the disability that remains and the activity of sarcoid, of neurosarcoid, I should say. That's for any neurological autoimmune disorder. You're welcome. I can find it. And then
Thank you so much again. That was
Thank
very
you.
informative.
I try and stay for the next one because I'm curious.
Hey, Tyler, right?
Yeah.
Thank you so much for doing this. Yeah, absolutely.
I'm looking forward to it.
So. You can just log on to your email. I've stopped the share.
Hello, everyone. I'll give you a bit of a chance to kind of grab some food and everything, and then we'll get started with discussing the eyeballs. That's what I'm here for today. All right, I'll make sure. All right, well, thank you everyone for having me out. My name is Tyler Loyson. I'm one of the PGY4 residents here going into retina, surgical retina next year. So I'll be pursuing fellowship in Minnesota. It's a pleasure to come speak with you guys about the eyes. I have plenty of pictures of eyeballs. So we'll just go ahead and get started. Give you a little bit of an overview of what we're going to talk about today. I'm going to really quickly touch on epidemiology as it relates to ocular sarcoidosis. We're going to spend a meat of this presentation going through intraocular manifestations of sarcoidosis because it's the coolest pictures, and also it kind of pretends a poor diagnosis for patients, particularly if they have posterior segment involvement, and we'll define what that is. And then we'll talk just very quickly about diagnosis. We kind of have our own Congress that met. We have our own criteria for diagnosing possible, probable, and definite ocular sarcoidosis. So we'll discuss that very quickly, and then we'll touch on management, focus a little bit more on the ocular specific management, things we can do to be a benefit to your patients. So we've kind of probably defined this a million times over, so I'm not going to repeat that, but I thought it was pretty cool that sarcoidosis was first identified in kind of a case series with 3 different men back in 1909, and it has been studied ever since then. As far as the prevalence of ocular involvement, it's a very kind of high range. The reason being is different studies will count dry eyes or keratoconjunctivitis sicca as a kind of a sarcoidosis, ocular sarcoidosis defining presentation. And those studies that take that into account had much higher prevalence numbers than studies that only look at like uveitis as the presenting form. So that's the reason for the large range there. The Retina Bible, which is Ryan's Retina, put this number at about 28%. And that's looking more specifically at intraocular involvement. 30 to 40% of ocular times that patients come into our clinics, they're actually presenting to ophthalmology clinic to us first, and then we send them over to you guys. So the important thing for us to kind of say right off the bat, it can affect any part of the eye and kind of the adnexal structures. So we'll touch on this just a little bit throughout the presentation. It most commonly presents as a bilateral anterior uveitis, and we'll define what that is. And conjunctival nodules are very common upon presentation as well. And this is important, as your ophthalmologist can help you, because this is a very easy area to reach to biopsy these nodules. And very easy for us to find on slit lamp exam. So roughly 30 to 70% of cases will present with uveitis. And kind of the categories that we're going to be breaking this down is intraocular sarcoidosis. We'll talk about ocular surface disease, orbital disease, adnexal disease, and we'll just touch very briefly on neuroophthalmic disease. So it's kind of an initial throwaway. Panuveitis is when every single structure of the uvea is involved. So this is the iris, the ciliary body, and the choroid itself. And each one of these structures in turn identifies what type of uveitis we're dealing with. So if we're looking at just the iris, that is our anterior uveitis. So that's affected most commonly in sarcoidosis. Intermediate uveitis involves the ciliary body and the vitreous cavity, which is just that jelly-like substance that lies in this, there we go, get my mouse here, this whole back chamber here. And posterior involvement or posterior uveitis is defined as involvement of the choroid, which is this highly vascular structure that lies underneath the retina, the light-sensitive tissue of the eye. So this kind of gives us a basic framework of which we can kind of build on. So I found this diagram online. It shows kind of what we're looking for, findings with ocular sarcoidosis in anterior uveitis. And it breaks them down really nicely. So oftentimes patients will present with pain, they'll talk about redness, and they'll discuss photophobia with us. Oftentimes our findings are on the cornea itself, and it's a little bit hard to kind of determine, 3D depth from this 2D image, but we'll discuss on the pictures going forward. But sarcoidosis commonly presents as a mutton fat style KP. So it's a very thick kind of collection of inflammatory debris on the endothelium or the backside of the cornea. Iris nodules are present in up to 16% of cases. These are actually granulomas of the iris. They can present either at the pupillary margin, which make them pretty easy to see even from the naked eye when you're not at a slit lamp. A little bit harder to see would be kind of these Busaka nodules, which are located in the mid-iris. And then kind of what's most clinically important and very difficult to see without kind of a specialized ophthalmic exam would be these tent-like structures that we actually find overlying the trabecular meshwork. And the reason that that's important is nodules that grow here or granulomas that form here can block the drainage system of the eye, leading to glaucoma. And this can cause permanent vision loss through damaging the optic nerve. So very important for us to find and identify those nodules, as they are really responsive to steroid therapy. So as far as going through the specific findings, this is just a picture from Columbia University of what those greasy kind of endothelial keratic precipitates look like on exam. They're not really visible from the naked eye. So this would be something we'd see more so on slit lamp exam. And again, this is just a collection of inflammatory debris on the endothelium of the cornea. As far as other findings, this would be a little bit easier to see from the naked eye. You can see this eye looks very irritated, red. Oftentimes patients will have redness right around the limbus. That's just the area where the cornea terminates and meets the sclera. And in addition to this, we'll actually find white blood cells and fibrin in the anterior chamber. So that's the chamber between the clear cornea here and the iris and lens kind of here and here as well. What I'll like to point out here too, because this is something that can be noted without a slit lamp as well, is what we call anterior synechiae and posterior synechiae. So you'll see this pupil here is abnormal in appearance. This is because it actually scars down to the lens capsule. So something that can be noted. You may notice that in a dark room, the patient's pupil will look a little bit more abnormal just because they have certain areas that scar down to the capsule and other areas that can dilate normally. And this is just showing you some of that scarring right along the trabecular meshwork here. And again, that's clinically relevant to us as it can lead to blockage of this drainage system and development of glaucoma. So these are just examples of what those nodules look like. Help us with diagnosis, a little less kind of clinically relevant, not necessarily related to glaucoma or any kind of worsening of anything in the eyeball itself. But these are those pupillary nodules. We call them Kepi nodules. These are the Busaka nodules here. Just again, granulomas of the iris. Important to note that Busaka nodules, when we note them, is pathognomonic for a granulomatous type of inflammation, whereas the nodules located at the pupillary border that may be a little bit easier to see from the naked eye can present in both granulomatous and non-granulomatous causes of inflammation in the eyeball itself. So these are the Berlin nodules that I want to draw that specific attention to. You can see here barely noticeable from our slit lamp picture, but when we're able to use a specialized lens to look at the trabecular meshwork, the drainage system of the eye, kind of pop right out at you. So this would portend a poor prognosis in this patient. So moving from the anterior structures to intermediate uveitis. So again, we're talking about where the ciliary body is affected by sarcoidosis and the vitreous cavity, or that jelly-like substance that lines the whole back of the eye in front of the retina. We typically find vitritis, which is more easily described. It's kind of this generalized haziness that you see in this picture where we don't really have a clear picture of the retina. And that's just from inflammatory debris and white blood cells in the vitreous itself. Vitreous you can think of kind of like a gelatinous matrix. So it can really trap these this inflammatory debris throughout, blurring our view to the back. There's also this phenomenon called snow banking, which is seen in sarcoidosis along with other forms of granulomatous inflammation, where you actually have a buildup of precipitate that is typically white or whitish in color, and it's kind of located very anterior towards where the vitreous base is. Other than this, we actually can see what's called vitreous opacities, or termed snowballs, a little bit smaller than vitreous opacities. They're actually white collections of inflammatory debris, and this would be on dilated exam. So as we move towards posterior uveitis, this would be where we really start getting concerned with kind of long-term damage to the retina itself. So posterior uveitis can actually present as kind of a multitude of different findings. This one that I highlighted here is just a granuloma of that choroid, that highly vascular structure. Why this would be clinically significant to us is because this can actually lead to a retinal detachment developing in that area, which can cause the vision loss to kind of present pretty quickly in a patient. These granulomas can also form right underneath the macula, which is just this darker area here, or the fovea in the macula. And if they are foveal involving, they can cause permanent vision loss in the patients as well. Other than this, we'll typically see kind of these punched out choroidal lesions. We can see what's called candle wax drippings, or kind of white collections along the veins, which you can see kind of here. We have some sheathing of the veins here, and kind of some cases, it's not as typical, but they can present as actually a blockage of the veins, which can lead to intraretinal hemorrhage. And what's worse, it can cause the development of new blood vessels to grow. So we call that neovascularization of the retina. Why this can be such a problem is because these new blood vessels are very leaky. They can actually bleed into the vitreous cavity, causing the vitreous cavity to kind of fill a little bit with blood so that the patient will lose vision from that. Sometimes these blood vessels can cause scarring or fibrosis between the retina, which you can think of kind of like a thin sheet of tissue paper, and the vitreous, which is that jelly-like substance. When this happens, as the vitreous moves, it can actually cause a retinal detachment by causing a break in the retina. And that would be something that would be vision threatening as well, often requiring a surgical approach to fix that problem for patients. So these patients need to continue to be followed in the ophthalmology clinic because these new blood vessels can grow anytime after these vein blockages. So other kind of complications of sarcoid uveitis particularly is formation of cataract, which the only real way we have of dealing with that is cataract surgery. In order to take the cataract out, we prefer that the eye be quiescent completely for about 3 months, because we don't want to cause any worsening inflammation where we already have a background of inflammation and making things worse in the eye and increasing the chance the patient ends up with, temporary blindness or permanent blindness in the eye. The other thing that we've already discussed at length is the development of glaucoma, which causes damage to the optic nerve from pressures that rise in the front part of the eye here. And the other thing I'd like to discuss is swelling of the macula, filled up of or a buildup of fluid in the macula, which is known as cystoid macular edema. This is one of the most common causes of vision loss in sarcoid patients and does respond very well to both intraocular steroids delivered either in just kind of injection form or an intravitreal actually insert that we inject right into the vitreous itself and will release dexamethasone over a period of time. As we move towards ocular surface disease, can I have 3 pictures here? We talked a little bit about the conjunctival nodules and the importance for us as ophthalmologists to help with the definitive diagnosis of sarcoidosis. As you can see, these nodules here on the conjunctiva, very easily accessible at the slit lamp, easy for us to biopsy and help with the diagnosis. Other kind of ocular surface disease that are a little bit less commonly seen with sarcoidosis include this finding here, which is actually called band keratopathy. It's actually just a buildup of calcium right underneath the epithelium or the first layer of the cornea itself. And you can get scleritis with this as well, which is just actually inflammation of the scleral tissue itself. And this can present a poor prognosis if left untreated, as it can cause kind of thinning out of the sclera, which can make a patient more likely to actually have an open globe with any minor insult, as the sclera can melt over a period of time if left untreated. Moving on to orbital and adnexal issues with sarcoidosis. Eyelid involvement is very, very rare. I actually have a picture of the cicatricial entropion, which is basically where scar tissue forms that causes the eyelid to invert in, causing the lashes to rest against the cornea. As you can imagine, quite a significant issue for patients, but this is so rare that there's only really been a few case reports about it. Much more commonly, if there are any orbital or adnexal structures to be involved, we're looking at the lacrimal gland. Lacrimal gland granulomas can form, which can lead a patient to develop dry eye symptoms. And this is also known as keratoconjunctivitis sicca. It's fairly common on presentation. It's been noted in patients anywhere from 5 to 60% on initial presentation to the ophthalmology clinic. As far as other issues that can be caused, if the lacrimal drainage system is involved with granulomatous inflammation, this can lead to tearing, because basically you are shutting down the drainage system of the eyeball itself, the front of the eye. And then you can also have granulomas form over the extraocular muscles, in the orbital fat, optic nerve sheath, and these can cause issues related to compression of any one of these structures, such as double vision, vision loss, permanent blindness. They can actually also raise the likelihood that a patient can develop a central retinal artery occlusion. So this is just a picture of that cicatricial entropion. You can see here, it's a little subtle, but this eyelid is kind of rotated in, and the lashes are actually resting here and up against the cornea. And this can actually cause a corneal abrasion, which can lead to an ulcer. So this is something that we would need to see the patient for to get them plugged in with an oculoplastic specialist to take care of that for them. And following right after the Neurosarcoidosis lecture, touch a little bit on neuroophthalmic findings. This can present as any one of the cranial neuropathies. Most commonly is presenting as a facial nerve neuropathy or an optic nerve neuropathy, but the extraocular muscles, cranial nerves that service extraocular muscles can be involved as well. So patient can present with double vision and have extraocular movement restriction on exam. Typically, this is due to either direct infiltration of sarcoid tissue of the nervous structures, or it's involved by kind of a space-occupying lesion putting compression on these nerves. So our diagnostic criteria, there was an initial group that met in 2009 and then again in 2017 in Tokyo, kind of came up with this, plenty of words, of ways that ophthalmologists can think about ocular involvement of sarcoidosis. And mainly to kind of summarize this chart, it deals with a lot of the findings that we've been discussing over the last few slides of, that would be present in uveitis with sarcoidosis. And then also touches on a lot of the other systemic workup issues that would be more in your guys' court. We also have the definite, presumed, and probable ocular sarcoidosis. It helps ophthalmologists kind of approach these patients because there are multiple causes of uveitis, and again, uveitis being one of the most common presenting forms of sarcoidosis, important to kind of give us a framework to work with. So as far as what ophthalmologists can do for management of intraocular manifestations of sarcoidosis, we can deliver corticosteroids. Topical steroids are the first line agent used for anterior uveitis. This is again when the inflammation is restricted just to the iris tissue itself. And we've had success even just anecdotally in plenty of our patients in clinic utilizing just topical antibiotics when inflammation is restricted to the anterior segment. As far as any type of the injections, implants we do, typically we'll approach these when there's posterior involvement of the choroid, involvement of the retina. We most commonly will first go to like a sub-tenons injection of a steroid, and I'll explain what that is on the next slide here. But we can also deliver implants that are a little bit longer lasting in cases that are a little bit more refractory, that will kind of release steroid into the eye over a period of months. So we don't have to do quite as much with those patients if they are refractory. And then immunosuppressive agents and biologic agents have been touched in the other presentations as well, but we'll cover them real quickly as well. So most commonly we'll deliver steroids underneath the tenons capsule for those patients that we don't feel can be controlled on just topical steroids. And this is actually delivered in this potential space here underneath the fibrous tenons capsule, which a lot of the text talks about. You can think of like a sleeve over the eyeball. Basically, this is a way of looking at it in surgery. We don't actually do this in clinic. We just use kind of a needle to get underneath here. But basically you have the conjunctiva, which is that skin that overlies the white part of the eye. And then underneath this, you have the fibrous sleeve of the tenons capsule. We prefer to deliver steroids here as it pushes them a little bit further away from the front of the eye. There's a thought that this may decrease the amount of steroid-induced glaucoma in these patients, but also the steroid can get closer to the posterior portion of the globe. As far as the role for immunomodulatory agents, there is no standardized approach for ophthalmologists. Typically, we start to consider these when patient requires long-term course of steroids or steroid failure. Ryan's Retina kind of recommended to start considering immunomodulatory agents after patients cannot be controlled on 7.5 milligrams per kilogram per day, equivalent to prednisone. So that's often used in our clinic, and these agents have been discussed already today. Biologic agents for management of intraocular manifestations are used a little bit more in caution, particularly because there are some newer reports of these TNF-alpha inhibitors actually causing a uveitis themselves. So ophthalmologists use caution when kind of moving towards biologic agents, and there are no good randomized controlled trials that actually show effectiveness of these. As far as ocular surface management, conjunctival lesions respond very well to topical cyclosporin. Keratoconjunctivitis sicca also responds to cyclosporin drops as well. Scleritis is typically going to be treated with systemic steroids or immunomodulatory therapy. As far as any of the orbital adnexal issues, eyelid lesions can be treated either with systemic steroids, or sometimes we'll do intralesional triamcinolone injections as well. And then orbital lesions that would be concerning for malignancy, where we'd want to biopsy, we may remove that in the OR. As far as complications of the therapy, as we touched on before, steroids can actually elevate the IOP and lead to glaucoma over a period of time if that's left uncontrolled. So important for ophthalmologists to get these patients on drops that will help suppress aqueous production. That's just the fluid that fills the front part of the eye, to keep that pressure as low as possible. Cataracts can form from steroid therapy, as well as just the inflammation itself. And we want about 3 months of quiescence before we would go in and take those cataracts out. And we discussed that at length already, cystoid macular edema, and reported about how it is one of the major causes of vision loss in patients who have ocular sarcoidosis, or one of the most common. As far as our review, we touched about the epidemiology. We discussed ocular manifestations with pictures, touched real quickly on the diagnosis, and then finished by talking about ophthalmic specific management of the disease. Basically, as ophthalmologists, our role is often these patients are presenting to our clinic in, again, 30 to 40% of cases, so we can refer them on for more definitive diagnosis. We can also be useful in helping with conjunctival biopsies, as it's a very easy area in the body to reach. We can do it right at the slit lamp in the clinic. So very, low mortality and morbidity with that procedure. And then also for following up any of these complications that may develop from treatment, and also managing, ocular sarcoidosis, which can be pretty common depending on, how we're defining our involvement of ocular structures. Again, whether or not we're including keratoconjunctivitis sicca or dry eye within that umbrella of terms. With that, finished. Any questions? Thank you. I'm sorry, what was it? So that's a good question. That also varies quite a bit. When I was looking through this last night, it mentioned it was anywhere between, I think, 16 and 40%. And yeah, they mentioned that it depended on whether or not there was a lot of pretest probability, like if they were blind kind of conjunctival biopsies versus if there was something defined on slit lamp in that study. So basically it kind of varied on whether or not we were doing a blind biopsy or not. Any other questions? Cool. Well, thanks, guys.
Thanks so much.
Oh, you're welcome. Thanks for having me. I can talk about it.
you want me to go or do you want me to wait? A couple people gone in, a couple have come out.
Maybe a minute or two and then we'll start.
I'm going to go ahead and get started. We have case reports now, and I think there are three. Pat, Oase, and myself are each going to. So unmute. We're all good. Yeah, Pat, Oase, and myself are each going to present a case, and I get to go first. And my case won't take 20 minutes unless you guys have lots of questions, so it'll be shorter. But before I start, I have a couple of really exciting announcements. And the first announcement is that Pat, Oase, and myself have entered into an agreement in principle with Dr. Robert Quinn at Michigan State University. Rob Quinn is a biochemist, and he has a laboratory that is specializing in microbiome research. And this is an area in sarcoidosis that the three of us have talked about for some time. There's virtually no research that has been done in the microbiome in sarcoidosis. And for a disease for which we don't know the cause, which may have infectious precursor antigens that are involved, I think this would be a really exciting area to explore. Rob Quinn has a lab where they have done investigations in cystic fibrosis and in the coral reef and a couple of other areas. But he's really excited about moving into a new area in respiratory medicine also. This idea has been met with, at least this week, enthusiastic support by Dr. Scher and Margot Lapointe and one of the deans at Michigan State University. So we're really excited about this. And what I envision happening is for us to be obtaining BAL fluid in patients that we identify with sarcoidosis. Rob Quinn and his group are very well versed in taking care of looking at BAL samples, and they will be doing analysis for the microbiome and also metabolomics, where they look for signature compounds in the BAL fluid. And so this is something that we intend to start. We ultimately hope to phenotype our patients with sarcoidosis and look for signatures that differentiate these different patients in a basic biochemical physiologic way. The other announcement is that we've also come to an agreement this week with Novartis. Novartis has a drug which is an anti-IL-18 molecule. IL-18 is elaborated by macrophages and leads to interactions with T2 effector cells to cause granuloma formation. And IL-18 has been implicated both in chronic granulomatous disease and in sarcoidosis. And it looks like we'll be a site for the anti-IL-18 study, which is a very early phase 2A study. There's absolutely no question that we're going to need lots of help with these two studies, especially the translational research project. And so anybody who's interested at all in helping with us, whether it's IRB and obtaining BAL specimens, identifying patients, so forth, there's going to be plenty to do, and we welcome help with that. So I think it's really exciting, and there's a lot of things going on. I'm going to talk about a case today that is a case that I'm seeing in clinic. And I picked this case in part because it's different from anything we've talked about today. So it won't have anything to do with the eyes or the skin or the neurologic system, at least not directly. So this was a 36-year-old healthy woman. And she had a history of mild asthma and polycystic ovary disease. She's a non-smoker. She has a financial job. Well, in 2019, pre-COVID, she had a URI. She was treated with steroids and antibiotics and bronchodilators. She didn't really get well. She had a persistent cough and shortness of breath. And so she had consultations with lots of doctors outside of our system, and they got a CT to try to figure out what was going on. And in this image of the CT on mediastinal windows, they saw some mediastinal and hilar adenopathy, which concerned them. And this is a blown up view of that where you can see the lymph nodes. And I think you'd agree that they're maybe not quite enlarged or close to the upper limits of normal, but there are several there. She also had changes in the lung parenchyma. She had some nodules and she had ground glass opacities. And she also had some bony lesions. You can look at her vertebral body there, and I've blown up a picture where you can see, I don't know if my mouse is showing up here, but there are lytic lesions in her bones. Her doctors at the outside institution were very concerned that she had malignancy, and she was referred to a local non-Henry Ford Cancer Institute for evaluation, and a PET scan was obtained. And I'll draw your attention to the inflammatory areas here, in the axilla, in the hyla. The spleen was highly active, multiple bony lesions. There were lesions in the inguinal lymph nodes as well. This is a good scan for this patient because it's going to be, it's something that I'm going to mention at the end about how useful I think PET scans are in this condition. Well, they were concerned about cancer, so they got biopsies. They did transbronchial lung biopsies and they found non-caseating granulomas, and they said, this can't be sarcoidosis, this looks like cancer. So they got a cervical lymph node biopsy, and that showed non-caseating granulomas. They said, wow, that's crazy. What about these bone lesions? That's gotta be cancer. So they biopsied the bone, and that showed non-caseating granulomas too. They got a quantiferin gold, and they said, that's negative, and then they sent her to me. And that's what's gonna happen to you guys as expert pulmonologists in practice. Well, what I'm going to talk about today is something else. This is a calcium level, and you can see in 2014, her calcium level, and I don't know why this was obtained, maybe for one of her other conditions years ago, was normal. When she presented to us, her calcium level was elevated at 10.8 in June of 2021. And we started prednisone in July when her calcium level was 10.9. We were very concerned not only about her multisystem disease, but her calcium as well. And because she didn't seem to be improving very much, in September, we added methotrexate to her regimen. So she was being treated with both prednisone and methotrexate. I felt really good over the next few weeks because her calcium level came down and she seemed to be improving otherwise clinically. And then in mid-October, she presented to an outside physician with nephrolithiasis. And at that time, when she had the nephrolithiasis on treatment, her serum calcium levels had come back down. Subsequently, I treated her with infliximab and her calcium levels normalized further. I talked with the urologist at the outside institution at the time of her nephrolithiasis. Her calcium level was 10.2 with their upper limit of normal being 10.5. The urologist fortunately had done a stone analysis and he showed that this was a calcium oxalate stone. And in addition, he did a 24-hour urine calcium level, which I thought was fantastic. And the calcium level was high. So this is a patient who has hypercalciuria, even though they have normal serum calcium levels. According to Sharma, who used to be the guru of sarcoidosis back in the 20th century, he wrote this review, which I thought was interesting. It's really the best thing that I can find, and it's 20 years old. And the data in his review is older than that. So this gives you an idea of how old this data is. And if you go looking for data on calcium levels in sarcoid, it's not going to be any more recent than this. So he states that about 10% of patients with sarcoid have hypercalcemia, but that as many as 3 times more have hypercalciuria. That may be true. There probably are case series in his review that support that, But I would suggest to you that most of us aren't measuring serum calcium levels or urine calcium levels, and maybe it's something that we should think about doing. The guidance in these patients with either hypercalcemia or hypercalciuria or both is to avoid high calcium diets, supplements, and vitamin D. And these patients have an indication, even if everything else is okay, for disease modifying therapy. I don't really have anything about this case to say other than 2 points. The first point being is that sarcoidosis can mimic metastatic disease. And so you have to think about that. It's also true that just because you find non-caseating granulomas doesn't prove sarcoid. It's a diagnosis of elimination. You can get evidence of granulomatous disease on pathology specimens if they're obtained in an area adjacent to neoplasm. So even though I had some fun with my local outside Henry Ford physicians, in fact, I think I was happy that they had had multiple biopsies that really confirmed the diagnosis. The second thing is to talk a little bit about calcium metabolism and sarcoidosis. You heard earlier today, it's related to the conversion to the active form of vitamin D in the granulomas. I have, in other domains, looked at calcium levels, and I think that if you're not measuring an ionized calcium level, you probably don't know what the calcium level actually is. The algorithms that we use to correct serum calcium levels are highly inaccurate. So these guys know I never measure an ACE level, and I always measure an ionized calcium level. And I think in selected patients, at least, we should think about measuring urine calcium. Thanks. Any questions?
I'm sure there's questions, but I have a question.
Yeah.
So let's say you had somebody with sarcoidosis. Would you treat them based on just an elevated urine calcium alone, or would you think they have to have complications such as renal dysfunction?
I'll answer your question with an anecdote. I saw a patient here at Henry Ford about a decade ago, and he came to me with hypercalcemia and hypercalciuria. And I recommended to this man that he take prednisone and come back to see me in a month. And he didn't do that. He went on his way. There's no other Henry Ford patients I know that are like that. But this guy never came back. The next time I saw him, Pat, was 5 years later, and he was coming to me for an assessment prior to kidney transplant operation. And the reason that he had renal failure was because of nephrocalcinosis and kidney failure because of hypercalcemia and hypercalciuria that was never treated from a sarcoidosis. So that's my answer. Treat these guys. It's a good question. How good is a spot calcium? I don't know. Are you going to get a 24-hour urine on every patient that you diagnose? That doesn't seem to make sense. Do I do that? I don't. What I do is I measure their ionized calcium, I monitor that, and I ask them about kidney stones. That's what I do. And I have more than one patient with sarcoidosis who has a history of kidney stones, and when they do, I check.
I would agree with you on that. Now, data for a spot urine calcium, it's usually a urine calcium to creatinine ratio, and it's not very sensitive per se. And again, usually it's when we have this higher suspicion that we're going to get 24-hour urine calcium on these patients to see would there be some justification for treatment. And the levels that we typically look at really is going to be above 250 milligrams for whatever they're measuring on the urine calcium. As being abnormal in sarcoidosis. Now, that data is also not robust. That's essentially the best we have.
There's almost no data in sarcoidosis that's robust. Do we see any sarcoidosis patients in Henry Ford? All the time. The question that you asked is highly amenable to being studied. I mean, that's something that anybody in this room could pick up and study a population of patients with sarcoidosis and look at 24-hour urine calcium levels, seeing what happens with treatment, and that would be worthy of publication. There's nothing out there.
Really, it should be covered, right? This is still standard care, like trying to look
Yeah.
for hypercalciuria.
Yeah, so you don't have to get extra money for it. You just do it because nobody really knows. Yes, sir. Yes. Yes. I switched to infliximab because the patient had the kidney stone while they were taking methotrexate and prednisone. So I made the assumption that they failed therapy and chose something else. If that hadn't been the case, I probably would have gone with methotrexate. I mean, there's nothing wrong with doing that.
If they had hypercalciuria, if you had checked
I would have, yes, I would have. Right. And again, that's a judgment thing. That's not based on any special knowledge or data.
Now, this is interesting too, because this is something I haven't done, because I would do what you did and just follow their calcium levels. But do you think there's a role for repeating a 24-hour urine calcium while they're on treatment if they have normalization of their calcium levels?
I think there probably is. And so this lady, for me, she needs a 24-hour urine calcium level follow-up, and she needs a follow-up PET scan. OACE has 45 of our patients on infliximab, and he's presenting that at CHEST, I hope, if they accept it, but it's in. And the whole thing is that we really don't have good objective endpoints that we're following in any of these patients. And when you look at that PET scan that I showed you guys, wouldn't this be a great thing to follow? What if we had PET scans initially in most of our patients, and then we had something like this to follow? It's expensive. The insurance doesn't want to pay for it. But what I would like to see is moving towards PET scan, MRI, something like that to objectify our endpoints. So we have something to follow. And by the way, nobody's done that really either. There's some PET scan studies. And the thing about this is maybe you do pick up organ system disease that you wouldn't pick up otherwise, like the cardiac disease or something else. So I think this is a great tool, and I'd love to see us being able to use it more.
I have a couple patients where this changed management because they were thought to have just sarcoidosis. We went ahead and did a PET scan, and now we're being a lot more aggressive on their treatment because of PET scans.
Yeah, and look at the spleen. I mean, there's about 10 people who've been reported with splenic sarcoid, and her spleen is red hot. Good.
We're gonna do a wall anyways. There's stuff. Have I? No, am I beginning to wonder what they're you know, if I could get it, wouldn't it? Really guess that you could deny it. I actually have one patient just
I think that's the challenge. Can you even get PET scan on everybody? That's not feasible either. You're introducing, there's some risk involved with that too, right? The radiation, and the cost of it. So you really, that's the challenge of figuring out who really would benefit from a PET scan.
As of right now, the only place that we're using this pretty routine is in cardiac sarcoidosis.
Yeah. All right. So I'll jump into my case, and this should actually be a great follow-up to Dr. Let's. It vanishes. Okay. All right, so we'll get started. I'm going to jump right into my case. So we have a 53-year-old female here with a history of smoking, 18-pack here. She has some CKD. As you know, often find a lot of them get diagnosed with asthma first, and then later found to have sarcoidosis. She initially presented to our pulmonary clinic with, actually to the general pulmonary clinic, with shortness of breath. It's going on for about a year or two. She reported being, so first thing is you're trying to establish the diagnosis, and she actually was diagnosed with ocular sarcoidosis through biopsy early in her 20s. So we're talking, 30 years ago in 1990s. You're not going to get that report, by the way. So treated with prednisone eye drops for years. She was treated with systemic steroids, bursts of it at different times, but never really advanced any therapy because of her symptoms and her active inflammation. She worked as a clerk actually at this hospital for about 30 years. And nothing too remarkable on exam. I did check the skin, so move forward. All right, so looking at the lab, so her creatinine has been relatively stable. Calcium at this time is about 9.7. There's no ionized calcium in the system for her. The highest non-ionized is about 10.8. Her liver function tests and blood counts are unremarkable. Again, I want to reiterate, what we're trying to do in our clinics on people that have established diagnosis is I'm trying to figure out, once you're past the challenge of getting a diagnosis, do they have active disease? So you're looking at all the data points that you have, trying to figure out, gauge, is there, because you don't have a PET for every single patient, right? So she has lung function testing that's been normal. And then you'll see later on, she is found to have some mild obstruction afterwards. Her cardiac testing, really, her EKG was normal in clinic, unremarkable echo. And then she actually had a stress test also to make sure she doesn't have any ischemic disease, and which was also quite unremarkable. So this was the X-ray she had on file around. This was in 2020, and you can see some patchy opacities bilaterally. And you can kind of get a better idea of this when we go into before I go into the CTs and so on. So 1990s gets diagnosed. 2009, 2015, there's maybe a visit or two, and she's been seeing ophthalmology here and there. Pretty asymptomatic for follow-up. 2019, where she comes in with the shortness of breath, she gets PFTs, which were normal, CT chest, which we'll take a look at in a second. Actually, early on, it was unremarkable, echoes unremarkable, and then she was started on inhalers. 2020, had a repeat CT scan, some patchy opacities again. And then 2021 is when we saw her, and she's having worsening cough, worsening shortness of breath. And she gets PFTs done, and this is the CT she has done. So we'll take a look. So it actually moves kind of fast, but I'll see if I can pause it too. So this is her CT scan. And also show you her mediastinal windows. I wonder if they can both run at the same time. So actually here, more so in the right middle lobe, there's actually a nodule. And actually, when you compare it to her priors, there's a new nodule. There's some progression of ground glass opacities bilaterally. So you really are questioning, is this progression of disease? Is there something else going on that's causing her shortness of breath? Plus you have a new nodule, and she gets this PET scan, okay? All right, so I'll play your PET scan for you. All right, so thoughts on that? And we'll play this too. So here's somebody who has biopsy-proven sarcoidosis, remained well-controlled, develops worsening symptoms, has worsening obstruction on her lung function testing, and then gets a CT, which is showing increased nodularity, and a PET scan that's pretty significantly positive, and especially in that high lung, it lights up quite a bit. So what would you do next? Feel free to throw out some answers. Any ideas? They're not on any treatment. So you're just seeing them, and this is what you see, from a symptom standpoint: cough, shortness of breath, maybe some night sweats, but you're worried about no skin lesions. You've seen the labs. What else? So EKG is unremarkable. Echo, she had a prior echo, but she has no cardiac symptoms. Right? So you're looking out for any heart failure symptoms. Palpitations is a very important question when they come in and you're looking for active disease, because you want to figure out if there are any ongoing arrhythmias, pre-syncope, syncope. So nothing like that.
One of the things I think comes next is talking with the patient, because the therapy, you're wondering about indications for treatment, and you're kind of on the fence. You've got some data that might suggest that you should, but then you don't have any clear indications. So talking to the patient about treatment options and side effects, I think at this point becomes really important.
Yeah.
And getting an idea of where they stand with their symptoms and what they might think about this becomes crucial. And so
Yeah.
I think that's one of the things that should come next.
Absolutely. I think that's what my first thought was too, that, she has symptoms, PET is positive, she has a right middle lobe nodule. I'm not sure about, I'm actually sending labs preemptively for, I might need TNF therapy. So I'm sending my, hepatitis profile, some quant, she actually didn't have a quant gold in the system, so I'd sent that too, but it is bothering me. Some of the things aren't making complete sense, that she has a right middle lobe nodule that's increasing in size. I ended up actually sending her for bronchoscopy, and she gets an EBUS TBNA, and this is what it shows. So station 4R, 4L, and 11RS is showing you non-necrotizing granulomatous inflammation. But we also see station 7 and 11I are showing adenocarcinoma. So now, that completely changes things for you. And there's no clear answer. She may have active inflammation and this carcinoma. Her BAL was sent, and respiratory culture gram stain, fungal and AFB were negative, but her PCP PCR was positive. Oh, one thing after another. I was actually calling her during Christmas break over and over, giving her another news and something else and something else. So I had sent those initial labs. So HIV was negative, hepatitis profile was negative, but then her quant TB is positive. Not to keep going into this, but she actually, she was exposed to TB as a child. She was treated for TB, and she's always had positive screening tests for TB. So that was really something that, not too much to worry about. But it brings up an important point that, we talked about mimickers the whole time, and we also talk about, we worry about malignancy or infection. What is it that's really causing the patient's symptoms, and trying to get to that underlying point. And I think this was a good learning point for me, and I thought this would be a great learning point for you guys also. So she ended up seeing, she was discussed at tumor board, started chemotherapy. She was treated with Bactrim for her PCP, especially during chemo for prophylaxis, and then managed for her asthma. This was quite recent too. So I think sarcoidosis and malignancy are a little bit of a controversial topic, because there is plenty of, it's well studied. The controversial aspect is, do they really have elevated risk of malignancy? And if there's one thing that you do see, is that lymphoma is the most common malignancy associated with sarcoidosis, specifically non-Hodgkin's lymphoma. Among the solid organ cancers, breast cancer is more common. In this meta-analysis done of 16 studies, there was an increased risk, relative risk of 1.19. And it was statistically significant during that first 4-year period. That's where there's the greatest risk. But when you look at it past that, going 10 years, it's not really statistically significant. Another important point is they are usually early stage cancers and early stage sarcoidosis. So they end up having a better prognosis overall. Something important to note also, immune checkpoint inhibitor chemotherapy specifically can cause drug-induced granulomatous inflammation. And it's interesting that once you stop this medication, it resolves. Something interesting from a skin standpoint, they actually noticed that patients with tattoos that developed, these lesions on their tattoos after getting an immune checkpoint inhibitor I thought that was quite interesting. And then infections and sarcoidosis. So it's important to note that, this is one of the leading causes of mortality in patients with sarcoidosis. And it's a combination of these things where they may have structural lung disease. Bronchiectatic patients are, the highest risk for getting infections. Do they have fibrocystic lung disease? Then they're at risk for aspergillus, for example. They have immunodeficiencies. So it's a paradoxical immune system. It is one that you have elevated Th1, T17 response, but in other areas you're seeing neutropenia, leukopenia sometimes. You're seeing basically an immature immune system and not being able to fight infections easily at times. But most of the infections actually show up on treatment. So you can see that on the left here. Bacterial infections more common with immune suppression. Mycobacteria, of course, with TNF. That's why we make sure it's part of our order sets to make sure we rule that out. Fungal infections with steroids, that's quite a big concern, especially aspergillus, and then PCP we just talked about. All right, so any questions, thoughts on this? I think the two important things that I would take away from this is never assume, never take it for granted. That's the challenging part of seeing sarcoidosis patients, that their symptoms, this possible inflammation, if there is any, could be from a number of different things, and especially if they are on treatment. So, and then, that's the challenging part. Go ahead.
So this isn't really about the other things, but she gave you this diagnosis you have already, but is there typically a role for bronchiolitis or that you thought she also had?
Yeah, so that's a good point. There are patients that we sometimes do bronchoscopy on, and they have that cobblestoning of the airway, and you wonder about airway involvement, especially when I have patients with cough, or they are definitely have obstruction developing on their PFTs. I wonder, I'm going to definitely talk about their clinical history. Do they have environmental triggers to help me go along with asthma? If I don't, I think they may have sarcoid involvement of the airway, and without bronchoscopy, I may not even get that too.
So that's a great question. I had Zach Morris's PFT database, and I had culled that down to a group of about 600 plus patients who had confirmed sarcoid and about a third of them were normal, and about a third of them had restrictive disease, and about a third of them had obstruction. And all of us struggle with the patient who's got obstruction on PFTs and sarcoid. Do they have asthma? If they're smokers, do they have COPD, or is it all about sarcoid? There have been some case series about treating sarcoid with inhaled corticosteroids. There's not good data. I think I do a lot. If they've got obstructive lung disease, I certainly do.
Right.
And you wonder if it would be a good treatment, but I don't think there's enough data for anybody to say, yes, that's the thing to do, but I can tell you a lot of people do that.
It seems like a lot of the triggers that you would have to do to kill treatment also trigger some.
Right.
So
Right. There's a lot of my patients that have 2 bullets, obstructive airway disease and sarcoid, and I do that on purpose because I don't know if it's a different diagnosis or the same. And a lot of those people get steroids.
kind of looking at it, it's like cumulative effect. If it's somebody who has mild disease and you don't feel the need that they have to be on systemic treatment, but they have this irritant cough and some obstruction, then I'll trial them on the steroids, see if this gets them under better control.
Another comment that relates to a different point in Oasis talk is that, just a guess, but I think not everybody who's a pulmonary fellow here or listening to this talk is going to stay in Detroit. Some people may go some other places. I can tell you that in the military, we used to send a lot of people out to the Southwest desert for desert warfare training, and a constant differential diagnosis for us was sarcoid versus coccidioidomycosis. We've got good TB tests, pretty good TB tests. Everybody in the room, I think, is thinking about TB when they see somebody with granulomatous disease. But you should be sensitive to the region that you're practicing in and realize that you may have local granulomatous diseases that you need to consider strongly. I had one patient ever who had non-caseating granulomas and negative microbiologic studies on bronchoscopy. And we gave that person steroids, and that person had toxisepsis, which was not a fun diagnosis to have. So you have to be aware of your local conditions and diseases.
I have a handful of patients that have histo, blasto, that were found later. And then you question, where they got this diagnosis of sarcoidosis and then found to have histo and blasto. Yeah, I think you've had that patient. Yep.
No, it was like doing residency. The patient had it. Was concerned that this might be possible sarcoid, but started at start that was doing Christmas, right? So the sign up wasn't very clear. The patient went into
No, yeah.
Nice job.
That's right.
All right, you guys ready for the last case? Excellent, fantastic. So I'm gonna just go ahead and go through this case. And there's gonna be a lot of stopping points. And a lot of this is just to really foster discussion because unfortunately, as Dan had mentioned earlier, we just don't have a lot of robust data in sarcoidosis. So there's a lot of just really expert opinion and then, some conditional recommendations here. So I'm going to talk about this patient. He's a 55-year-old male, lifelong non-smoker, really overall healthy, had a BMI of 28. Starting back in March of 2012, he was having progressive dyspnea over the course of 5 months without any kind of inciting event. He works in a leasing office, didn't have any significant exposures, no family history of pulmonary disease. Prior to this, he was exercising fairly regularly, but now he was really limited by his dyspnea. He didn't have cough, chest pain, no fevers, chills, no weight loss, no night sweats, no palpitations. He had spirometry. This just showed mild obstruction, but the pulmonologist at that time said his dyspnea was out of proportion to the findings. He had mild improvement in ICS-LABA therapy because there was concern for mild intermittent asthma with this obstruction. And given his symptoms, he was referred to cardiac evaluation. At that time, had an exercise echo, white blood cell count, comprehensive metabolic profile, and BNP that was unremarkable. They sent him in for a sleep study, showed some mild OSA, and he was started on PAP. In September of 2012, he had progressive dyspnea. He was hospitalized, had a CT scan that showed some upper lobe predominant alveolitis. He was given steroids and antibiotics, and he had significant improvement with his dyspnea at that time. From about 2013 through 2019, he was just treated for underlying asthma COPD overlap, even though he was a lifelong non-smoker. And he was given a variety of inhaled corticosteroids, LABA and LAMAs. He was requiring about 2 to 5 courses of steroids a year for exacerbations. Also during this time, he had intermittent chest x-rays that were unremarkable. Right. And then finally, in January of 2019, they got a repeat CT scan of the chest. And so these are just some representative images. So you can see he's got some ground glass pacifications. He's got some reticular changes. We get down into the mediastinum. He has some adenopathy, although not, grossly enlarged on there. We go to the lower lobes, and this is essentially diffuse throughout. I didn't have the images from the 2012 to compare it to say, did he have, the same findings at that time or not? So at this time, he's still at the outside hospital, undergoes a bronchoscopy with trans TBBX showing non-casein granulomas. Other workup for infectious etiologies were unremarkable at that time. And so essentially he was diagnosed with sarcoidosis. They started him on prednisone 60 milligrams daily with a plan to continue this on for 6 months and then decrease the dose for him. And so this is where I want to stop and just kind of, have a discussion about, how much prednisone should we start when somebody gets diagnosed with sarcoidosis. So, you kind of go on your up to date and you see 0.3 to 0.6 milligrams per kilograms, which essentially is going to come out to 20 to 40 milligrams a day. I did not see a whole lot of sarcoid during my fellowship. And when I came here, I started seeing a whole lot of these patients that are coming in. And, probably what struck me out the most is that, how much complications they had from these high doses of steroids. And so, when I talked to Al, and I think even when I talked to you, Dan, really it was more favored to start lower doses of prednisone, 20 milligrams over these higher doses of steroids. And I don't know if anybody has any other opinions on that or what you guys do.
I think you have to, I think you have to judge the patient. And in talking to some of the other guys like Bob Hoffman, I think everybody is now, in most patients, going with about the 20. You guys, because of the population that we see, you don't see Lofgren syndrome. If you saw a 25-year-old with high fevers and hemodynamism, bad shortness of breath and cough, you give that person 50 milligrams of prednisone a day, next week will be their favorite person in the world because they'll be better. So there are some people you want to treat with high dose, but I think 20 for most people is good.
Yeah, and so, and just to kind of let you know as a follow-up kind of discussion point, Lofgren's, I'll be honest, I haven't seen that. So I haven't had the opportunity to treat them with high dose steroids. And the only other patient populations that I would tend to treat with higher doses of steroids are going to be the neurosarcoidosis patients and then also cardiac sarcoidosis. And so I haven't had the other patients, especially somebody who is just essentially outpatient, on 60 milligrams may have been a lot, but I wasn't there at that time. And then the other question is, how long do we keep them on this steroid dose before we start to decrease it? And so again, I think, unfortunately, where this goes down to, it depends on the patient. And so for me, if I have a patient who I think is going to have a really hard time with steroids, they're already obese, they have diabetes, they're concerned about the side effects of the steroids, then I'm going to try to start decreasing them sooner. But typically, as my pragmatic approach, I try to do 20 milligrams for about 3 months, unless they're not tolerating it. And then I might start to consider coming down, but I'd want to see them in clinic before coming down. I don't know if you do anything.
I was gonna say, it's a huge service to the patient when even if all you're doing is actually decreasing the dose of steroids. And that's how I think also patient depending on how active their sarcoid was, or what is the end organ damage that you're worried about. I'm trying to be as aggressive as possible trying to do those steroids, because if I need to use something, if they run into symptom problems when I do the steroids, I'm going to use the steroid sparing agent. But they're sitting there without one on steroids, chronic vascular necrosis and obesity and all the bad things we've seen. I try to be aggressive, but it depends on the patient population that we're involved in.
Yeah, for me, it's a 6-week follow-up and reassessing, like these guys are saying. And I think I have at 3 months, I either want to be nearly off steroids or I want to be starting the steroid sparing agent. That's really where I'm at.
Yeah. And so, there were recent, clinical guidelines that came out that Dr. Lett was a part of. This came out of the European Respiratory Journal. And really, as far as, their recommendations, actually, I'm sorry, they didn't make recommendations on the dose of steroids. It was just, this is the usual dosage. And then, trying to get them down to lower doses such as 5 to 10 milligrams and then following up with them. And so, one of the other questions I had, and I don't know the answers to this, is, and I was curious your thoughts, Dan. Do you ever use any other steroids like Medrol in any of these patients, or is it always prednisone?
No, but that's just me. I never use pulse dose, and I never have done that. I don't use other steroids. Alcohol is used to give intramuscular injections. I don't know why not, and I don't know any reason why the others wouldn't work. But I've always used prednisone.
Yeah, I had the same. The only time you have one patient on Medrol, and this is just because you're really adamant she didn't want prednisone, but she needed something. She wasn't interested in methotrexate, and so we said, all right, well, we'll do Medrol and see if this works. And I don't know if it's placebo effect, but this is working out well for her. And again, going to the pulse dosing, really what you'll see in the literature is just if there's impending respiratory failure, which I have never seen in pulmonary sarcoidosis alone. But the only other time was what we had heard earlier with neurosarcoidosis. They'll still pulse these patients for 3 to 5 days and give it to them. And I think we just don't know the right answer, but it is a very disabling disease. And so I don't think it's unreasonable. And then the other question is, when to start tapering. Oh, and I'm sorry, go ahead. To be honest, if there was a time where I'm going to have a patient that's not responding to that 20, I would increase it, but at the same time, I'm going to be starting a steroid sparing agent. Yeah.
20 years ago, I would have increased the steroids. Today, probably have methotrexate.
And then the other question is just, when do we start tapering? And so this is also, we don't know when the best time to start decreasing the dose. I think it's reasonable, like Dan's saying, seeing them in 6 weeks, trying to get them on lower doses at that time. And every patient's going to be different. And really, the British Thoracic Society had come out with their recommendations on pulmonary sarcoidosis. And they don't give this timeline, but they really allude to maybe after that first month, trying to start coming down on these steroids. So going back to this patient case, so over the course of the year that he was at the outside hospital, they were trying to taper down his steroids. They got to 2 milligrams of prednisone, but he had frequent recurrences and needed to increase back to 20 milligrams. During this time, he was found to have avascular necrosis of the hips, had a lot of chronic hip pain due to the steroids that he was given. So he was referred to us. I had seen him in January of 2020. At that time, he was on prednisone 10 milligrams. But still had recurrent dyspnea and cough when decreasing the amount of steroids below 10 to 7.5. We did a workup. There wasn't any evidence of any extrapulmonary disease for him. So he was solely pulmonary sarcoidosis. And these are his PFTs. This is when he first went in to the outside pulmonologist. So he had he actually did. He had a mild restrictive pattern of disease. And then when we had seen him, he had a moderately severe obstruction and also had a diffusion impairment at this time. So he definitely had progression of disease, not surprising with his CAT scan. And so, really the next question would be is, when do you start a steroid sparing agent? I think in this gentleman, it's pretty easy to say like, all right, he's failed steroid taper. He's having complications of the therapy. And so, and we already kind of addressed, when they're not doing well, if we think that we need to go up on the steroids, that's going to be the time to choose. And then the second question is just going to be, which steroid sparing agent to choose. And so just, for the sake of time, this is just a part of the cutout from the European Respiratory Journal and these guidelines. So when we start looking at, when we start looking at this and we see these patients that are either at high risk or they're having disease relapse, really there's a conditional recommendation to start methotrexate. And again, it's because we don't have robust data, but this is the data that we have. And so, why would we choose, another agent over methotrexate? Because this would be the question that you want to ask yourself. And it's just that, are they going to have side effects from the methotrexate? So where do we avoid this? We avoid this in patients that have liver disease, patients that have significant renal impairment. And so we may look at other choices such as azathioprine. I'll be honest, I have a couple patients on mycophenolate. We use hydroxychloroquine. This isn't very good in pulmonary sarcoidosis, but it's still an option. I use it in other diseases. And then I don't have any experience with leflunomide. I don't know if you use that, Dan, at all?
No, mostly methotrexate. My second choice almost always has been azathioprine. And the hydroxychloroquine is usually, for me, it's people with skin disease.
Yeah. Yeah.
Yes, and that's what I'm trying to say.
So, when I had seen him, we initiated on methotrexate, starting at 10 milligrams weekly and always starting on folic acid. We continued the prednisone 10 milligrams since he was still symptomatic. I wanted to make sure he was tolerating the methotrexate. So we'll follow this with their LFTs and renal function monthly for at least the first 3 months. And as long as they're tolerating it, in his case, I really wanted him off the prednisone. So I went ahead and increased his methotrexate after I knew he was tolerating it. And then after 3 months of therapy, started decreasing the prednisone. However, he did relapse after we had done a slow taper. So we were doing 2.5 milligrams every month because I was worried about his symptoms recurring. And so once he got down to 2.5 milligrams, he started to have symptoms again. And so, really how fast to taper steroids is that probably a recurring theme is that we don't know. It's really, and it depends on the patient. And so general recommendation is to have that initial course for at least 3 to 6 months of treatment, and then tapering down to 5 to 10 milligrams daily, and then considering treatment for 1 year, depending on the patient. And so if they're tolerating lower doses, such as 5 milligrams, that's really my cutoff. Anything more than that, then I want to start a steroid sparing agent. Then I'll allow that. And then, interesting when we start saying like, well, how do we get them off of steroids? This was an interesting take that this is the first time I had actually seen this in an article from the British Thoracic Society. They said, once you're down to 5 milligrams, decreasing by 1 milligram every 2 weeks, and then 1 milligram every other day for 2 weeks, and then stopping. I have never done this, although I'm intrigued to try it. I'm more on the case of, if it's 5 milligrams, we can go ahead and just cut it and just let me know if you're having symptoms after that. Very rarely do I have to go down more. So I don't know where this was an expert recommendation, but I said, all right, well, when I have that patient who really can't tolerate or has, a significant issue coming down on their steroids, maybe I'll try this next time around.
There's a few patients that you'll meet that are so anxious about getting off steroids, and have maybe one that really needed to be on 1 milligram at a time.
Oh yeah.
Sorry.
No.
So we use like a ton of prednisone, not just like cutaneous sarcoidosis, just polycystic tissue disease. I get conflicting opinions from dermatologists or rheumatologists in terms of like, when do we start a bisphosphonate to try to prevent some of the osteoporotic complications? Because obviously, like, you're starting bisphosphonate, you can have other issues with that, in terms of like osteoporosis in a jaw or something like that.
Yep.
And we also start worrying about pneumocystis for prophylaxis as well. And we typically don't, my perspective is like, generally, if I'm starting a second immunosuppressant like prednisone plus methotrexate, then I usually do try to move towards starting pneumocystis prophylaxis. But I was curious from the pump perspective, if you guys start bisphosphonates or like Bactrim for those sort of.
You know, we don't, but I think we're fortunate in sarcoidosis because of the hypercalcemia.
Yeah,
I don't
that's
see a
true.
lot of these people having osteoporosis problems unless they've been on the steroids for years. And that's where I've seen it come up.
What I do is so one of the reasons I've become eager about tapering is because I think the current recommendations, if they're on more than 20 of prednisone for 3 months, they should be on pneumocystis prophylaxis. So my goal is to get them below 20 before 3 months is gone, so I don't have to do that. That's one thing. And then I frankly will refer, if patients are on steroids for a long time, I refer them to for management because I don't want to get involved in driving that stuff.
Yeah, and usually I'll just make a recommendation that they should have a bone marrow density scan. Yeah, I'm seeing their primary care physician. Now it's interesting on pneumocystis, because we don't see this a lot in sarcoidosis. And the case reports that are out there. Except the voice, yeah.
Actually, I just saw that patient. I didn't think it was.
True. I was gonna say because the PCR is very sensitive now here in the lab. Yeah. Yeah, because it's, when you have this influx of CD4 cells within the lungs, I mean, you're not usually at risk of having hemocystis. And the case reports for sarcoid, it's when they're on high doses. It's really, the ones that I was looking at was like 50 milligrams for a prolonged period of time. And those were the ones that they were having these breakthrough cases of pneumocystis. So, I used to put a lot of people on PCP prophylaxis having the dual immunosuppression, and now it depends. If it's really like I'm going to come off the steroids, then I'll hold off unless we can't.
Yeah, if I have somebody that's attracted to
Yeah. And then from here, it's just, when do we start to think about, when should we start another therapy such as anti TNF therapies? So, again, when we come to these guidelines, we're looking at, are they having continued disease or are they relapsing on this? And again, this is a conditional recommendation for infliximab because this is the data that we have, or another anti-TNF agent, which is going to be Humira or adalimumab. And so this is going to be the time where we start these patients. So, the one question somebody may have is that, well, why not start another steroid sparing agent? And, depending on the patient, that may not be the wrong answer if it's something that they're concerned about the risks of anti-TNF. And I think for us, as we've kind of gone on over these last couple of years, we just see the success rate with a lot of our sarcoid patients who have been refractory to steroids and these steroid sparing agents, that I would much rather get them under control with shared decision making rather than keep trying another agent and then allowing their disease to continue to progress. I don't know if you have any different thoughts on that, Dan. Yeah. And so what's nice, especially here, in our infusion center, they work with us. They're going to make sure this patient gets their labs. They've had their screening with their quantiferin and their hepatitis. And then if they're having issues or if there's problems, there's a really good open line of communication that really makes me feel better about having these patients get the infusions that they are being monitored well. And so, for him, because of the complications of steroids, we started the infliximab in September of 2020. I continued on both the methotrexate and the prednisone, but then after his second infusion, he had significant improvement with his dyspnea and cough. And so, you can see on his PFTs here, he had quite a significant change and improvement just after that second dose of the infliximab. And so, how long after the infliximab initiation do we start to decrease the steroids? It really depends on the patient. Usually for me, if it's a complication like him, I started actually right after he was done with his initial course. So after his third dose. But I think, Dan, do you ever decrease them sooner than that, or as soon as you start the infliximab, or when When do you typically?
Yeah, some people have patients on 2 or 3 agents to include infliximab, and I don't like to do that. So after a couple of doses, I'm trying to get rid of the methotrexate and steroids.
Yeah. Yeah, and a lot of times I would say I probably lean more towards the steroids just because of the side effects of them. And I honestly, like I've had a lot of really good success with the infliximab that, we can come down off of these pretty quickly. And then the other question, which is just, how long do we continue treatment with infliximab? And so we don't know that answer. And so, going to my patient, so after his 3rd infusion, we started decreasing the prednisone 2.5 milligrams every 2 weeks. And then once he was off the prednisone, we started taking off the methotrexate 5 milligrams every month. I would say my practice has changed now. I'll probably just take off the methotrexate. I don't really have that much in the way of concerns about tapering it off, just given the half-life. And then unfortunately in August of 2021, he was let go from his job, lost his insurance. So he missed an infusion and had recurrence of symptoms about a month after his last infusion. We were able to bridge him with a short course of prednisone, and then he was able to resume his infusions with actually immediate improvement again. And so, for him, because of his continued relapsing disease, my plan is actually just to keep him on infliximab as long as he's able to tolerate. And then also, there was something as I was looking through his case, and we were planning to get a repeat CT scan of the chest, but unfortunately, with his insurance loss, I haven't been able to see him, but we're still communicating over my chart to make sure that his disease is controlled. And so with that, what questions do you guys have? Yeah.
So with infliximab, like we had that patient with paradoxical adverse effect, like is there a role to continue steroids in the initial? Is that why we continue the steroids to like the first 3 doses, or it's just sporadic?
So there's a loading protocol for infliximab, and so essentially you get the infusion on day 1, 2 weeks later, and then 6 weeks later, and then so essentially from there you're loaded, and so that's why we tend to choose the 3rd infusion to start decreasing this.
Do you just keep them on the steroids, or do you bump up the steroids?
If they have that adverse reaction, I haven't had somebody who's been on steroids have an adverse reaction like that. In that case, though, I would just be stopping the infusion, and then we would readdress as far as what else could we try. So we've had it where we've had somebody not tolerate infliximab, we've been able to put them on adalimumab or Humira, and then we have vice versa, where they were on Humira, they had a paradoxical reaction to that, and then using some other agents.
Is there a reason why we would choose one over the other?
So usually it's patient preference on this. So I like infliximab because they get monitored in the infusion center. Humira is nice because it's the patient gives it to themselves. So they come into our clinic, they'll get shown how to take it, and then at home they're able to do their dosing every 2 weeks. But they should still have monitoring. They should still have their LFTs evaluated. They still need to have their hepatitis screen every year, their quantiferons completed. So there's still things that need to be followed with those patients, but usually it's just patient preference.
There seems to be a lot of insulin-dependent diabetes in our steroid patients. So we tend to notice they have no problem giving themselves injections Q2 weeks as opposed to 2 weeks. But it's not bad. Sometimes we have to decrease it in 4 weeks. But I had a patient that just said, insulin shots, I can do
Sometimes they're also stuck by insurance. So insurance, they have to pay more to come into an infusion center. You're paying the nurse, you're paying the facility fee, and then the medication itself, where the Humira, it's just the medication. Yeah. I would say usually we get better results with the infliximab. So usually it's like they get on infliximab and then we stop everything else. This is a great question. It's all about the money. So this is what we end up dealing with a lot in our clinics, because there's patients where we really it's contraindicated to use something like methotrexate, or they have pretty significant disease where I'd rather get them under control. They have diabetes, they have cirrhosis or fibrotic changes on their liver. They have chronic kidney disease where a lot of these steroid-sparing agents, steroids themselves are going to be an issue. You know, they have uncontrolled diabetes, and so it's things I want to get them off immediately, and I want to go to this, but there's a lot of pushback from insurance because of the cost of these medications.
So it's really not second line.
Infliximab would essentially be third line on there.
Methotrexate is the most well-studied medication. It's not like it does not work. It's just slow. It's slower. So especially for things like neural or ocular involvement or cardiac involvement, where I'm not going to wait 6 weeks, or at times try to wait for methotrexate to work and keep them in high dose steroids. We need quick control. So yeah, that's
No, no.
I was curious, like, so for a patient like this, are they on infliximab now indefinitely, or?
So I'm going to keep him on it indefinitely, just because he's had relapses once he's been taken. A lot of times the decision is made for us because their insurance changes. They'll have maybe a complication like they've had an infection. So we're going to come off of it for a time and then see how they do. But a lot of times, in his case, I generally what I would think at least a year and then readdress if we're going to be coming down off of this. And in these cases, there are dosing for infliximab. And so you don't have to completely come off it. We could go from 5 milligrams per kilogram down to 3 milligrams per kilogram and see, are they doing well? Are they tolerating this? No guidelines for that. No.
I was gonna say the general course of the disease is it's not something that inflammation comes on, stays on forever. We do keep trying, but yeah, refractory patients are hard to,
Usually if they're still having sarcoid after the 3rd year, it's likely this is going to be a lifelong disease.
These people, they decide to start cases is it always symptoms plus like you have to have PFT data showing it's a little plus CT scan? Is it purely just if they have bad enough symptoms and like confirm
If they have bad enough, I would say it's that latter. If they have bad enough symptoms where they feel like they need to have treatment, then I'll start them on treatment. Now, in those cases, usually if I don't see systemic findings, I'll do a quicker steroid taper. Like I'll do 20 milligrams per month, 15 milligrams, 10 milligrams, 5 milligrams and off. Just do a quick taper and do 3 months and then see how they're doing after that. But yeah, if their symptoms are bad enough, and we talk about the risks benefits of treatment. I've had a couple patients where it's just been an irritant cough that just never goes away. We tried using inhaled corticosteroids and it still persisted on. And then really as soon as they get on a little bit of prednisone, it's gone. And then they're doing okay.
Yeah, we don't use,
Don't use Acthar.
send them to us and we'll get them off Acthar.
Send them to pulmonary and they will get them off Acthar. It is too expensive.
And we, honestly, it's very, the patients are usually, they have a phenotype, those patients that are on Acthar gel. Yeah,
What is it? It's like inhale?
no, it's a subcutaneous.
Subcutaneous. Oh,
It's
okay.
injections. Basically, they sell it as a hormone that's gonna cause your own body, your adrenals to release more steroids and control your inflammation. You're
Oh.
not
It's just
getting steroids.
ACTH.
Oh,
It's not really, yeah. that's
it's like
essentially-
doing a stem test, like, but like giving the
essentially
co-stimulants.
all the
Yeah.
time.
Okay.
What they
Thanks, guys. Goodbye.
actually farm this.